Good morning, everyone. My name is Ai Chengguo. I'm from Department of Pediatric Surgery with the China Hospitals, China University. I'm here to talk about link and MRA core expression analysis of congenital binary dilatation. Next. So as we know, CBD is a direct malformation often associated with pancreatic core binary malformation. Second, totally types 1A, cystic, and 1C, fused form can constitute more than 90% of CBD patients. Cystic and diffuse form CBD differs in clinical manifestation, may represent two disease entities of CBD. For example, cystic CBD often present with an earlier onset of symptoms in the infantile period and a shorter duration of pancreatic reflex, but larger dilated diameters of the common bile duct. So we wonder what is the corresponding difference in pathogenesis under the context of clinical feature. So to elucidate the genetic basis of CBD, we performed link and MRI sequence and bioinformatic analysis on 18 cystic and 18 fused form CBD samples. Especially, we include only typical cystic or fused form CBD, which means the cystic type feature a dilated segment exceeding 3 centimeters and a sterotic segment of the distal common bile duct that can be visually intraoperatively. Next. In the result, we defined more than 1,500 and 1,800 different differentially expressed MRA and link RS between cystic and fused form CBD. Second, the core expression models was built to find high collaborative gene set and contract associated between gene set and phone types. Then a key model, the brown one, was identified. It had the highest correlationship with the classification of CBD. Third, target of link RA was projected to explore the possible function of link RA in CBD. All the enrichment analyses, such as scale and KGG enrichment of DG key models and target genes, was obviously enriched in hepatocore binary system development, liver, and pancreas development. And the PPI analysis shows the key model and target genes. Finally, we measured HAP genes expression levels via RT-qPCR to validate the sequence result. Our conclusion, our study suggests that link RAs may modulate pancreatic binary duct development differently in cystic and fused form CBD, providing new insight for etiology study and clinical treatment. Thank you for listening.
Thank you very much. Very good, good results. But we have no.
Good morning, everyone. I'm Dr. Zhang from Department for Pediatrics. HPE remains the primary surgical procedure for BA, but most patients require neurotransplantation after HPE. This study aimed to identify preoperative factors associated with jaundice clearance, as well as predictors of 2 and 5-year native liver survival for infants achieved jaundice clearance after HPE. Patients diagnosed as BA underwent HPE from 2011 to 2021 were retrospectively analyzed. Infants with jaundice clearance were enrolled in this study. The pre- and post-operative liver function biochemistry were evaluated. The statistical methods included KM curve and the log test to estimate the native liver survival, and Cox regression model to identify variables associated with native liver survival, and ROC were used to evaluate the predictive value. The average age of this group at HPE was 62 days, and we found that age at HPE and preoperative TBA were associated with jaundice clearance, and 68 patients survived 2 years. Univariate analysis, preoperative univariate analysis, the albumin, total bilirubin, conjugated bilirubin, and the TBA at 6 months after HPE are associated with 2 and 5 year native liver survival. In multivariate analysis, conjugated bilirubin was the only factors. The only factor was 14 millimole per liter. Albumin and conjugated bilirubin were factors associated with 5 year native liver survival. The AOCs were 0.894 and 0.95. Anti-cut-off value were 39 gram per liter and 14 millimole per liter, respectively. So our conclusions: age at HPE and TBA were associated with jaundice clearance. Preoperative factors are not predictive of native liver survival. For infants with cleared jaundice following HPE, conjugated bilirubin could be used to predict 2 year native liver survival. CB combined with albumin could be used to predict 5 year native liver survival with good performance. Thank you.
Thank you very much.
Thank you, Chairperson, and good morning, everyone. The purpose of this study is to review long-term outcomes of congenital cystic lung disease, or CCLDs, after surgical treatment in children. For eligibility criteria, we included the studies with more than 2 years follow-up period. After screening, 27 articles with 725 patients were included. Only 0.4% of articles reported concrete outcomes. Most of the papers reported with insufficient or unusable data for systematic review. This slide shows the summary of results about lung function. 17 articles evaluated lung function. Also, 9 articles didn't report the percentage of abnormal patients, but they had slightly decreased lung function. When limited to the studies providing percentage of abnormalities, the cases with abnormal 51% were up to 44%. In addition, 3 articles which included the healthy control group showed that the patient group had lower FEV1% or FEV1. The exercise test is examined in only 2 articles. In the top panel, 10 articles investigated pulmonary morbidity, and approximately 25% had asthma diagnosis. In the middle, the prevalence of musculoskeletal deformities was 25%. Lastly, also 3 articles investigated neurodevelopmental outcomes. The result is inconclusive due to insufficient data. In conclusion, the long-term outcomes reported to be slightly worse in CCLD patients than in healthy controls. However, due to inconsistent evaluation methods, the overall picture of long-term outcomes remains inconclusive. Thank you for your attention.
And we have still one next speaker. Miho Watanabe.
And I'm from Osaka, Japan. So, okay. So the most congenital cystic lung lesion is diagnosed by the fetal ultrasound, but these lesions include the These lesions include the TPAM, macrocyst larger than the 5 mm in diameter, and the microcyst smaller than 5 mm in diameter. And the BPS which involved the cystic feeding artery as well as bronchoatresia with a hyperechoic lung lesion like this. And we performed a total of 31 cases, first classified based on the surgical pathological diagnosis, then review the fetal ultrasound characteristics. The result is this. The first, we do see the CPAP type 1 and the BPS and BA in this group, but there are no CPAP type 2. And the second, the BPS and the BA has both macrocystic and the macrocystic features, which are making them appear similar in fetal ultrasound. And the third, not all of the system feeding artery are seen in BPS. And then lastly, we didn't see any atretic bronchus and mucocystic in the BA group. In summary, the CPAP type 1 can be reliably diagnosed prenatally with fetus ultrasound, but the BPS and the BA are challenging to diagnose prenatally, especially when the key findings are absent. Thank you.
Okay, thank you.
Good morning. Thank you for the opportunity. We're going to talk today about the diagnosis and management of congenital myenteric hypoganglionosis. So pediatric intestinal pseudoobstruction is a clinical challenge. There are various underlying causes exist for this series of poorly understood motility disorders. One of them that presents in the neonatal period is congenital myenteric hypoganglionosis. There's often failure to pass meconium, bilious, emesis, and abdominal distension. There's dilation of proximal small bowel with a relative distal transition zone, and stoma is nearly always required, and lifelong TPN. This is a case that we had, and you can see that the distal bowel often looks less dilated than the proximal bowel. This patient had 24 centimeters of decompressed distal bowel. At the first operation, that bowel was removed and an anastomosis was performed, but the patient did not do well, and they required return to the operating room, ileostomy, and gastroscopy tube placement. We sent this patient's histology slides to a pediatric pathology expert in Seattle named Dr. Raj Kapoor, and he made a diagnosis in this patient of congenital myenteric hypoganglionosis. Specifically, there are a decreased number of ganglion cells which have to be compared with age-matched controls. There's 20% of the normal, and this is in the myenteric plexus. Submucosal plexus looks normal. It's the myenteric plexus that has the diminished number of ganglion cells. The cells also look immature, and there's markedly diminished antinuclear neuronal antigen and calretinin, suggesting the pathology is due to these intrinsic primary afferent neurons. So in summary, congenital myenteric hypoganglionosis should be considered in neonates with pseudointestinal obstruction, and the way to diagnose this is with pathology, and it is difficult to diagnose it. You need an expert who's good at looking at this in pediatric pathology. For us, it's Dr. Raj Kapoor at the Seattle Children's Hospital. We sent our slides there, and he made a diagnosis. And by doing this can spare patients and families travel to specialty centers that have motility testing, endoscopy, and a bunch of other procedures, because once the diagnosis is made histologically, it's done. Unfortunately, Dr. Kapoor has another series of patients that does not include ours of 13, and all of them require lifelong TPN because the process involves the entire intestinal tract. Thank you very much.
Okay, thank you.
And NR1H4 expression, 3 cluster analysis and immune profiling. We cluster BA patient based on PPR alpha, NR1H4 and MET3 expression, and examined immune cell pattern in those clusters. For experiment verification, we verified our finding with 58 cases from our hospital using technique like immunohistochemistry, PCR, and Western blot analysis. Our finding reveals PPR alpha and NI1H4 expression were significantly lower in the BA group compared to the control group. BA patients with low PPR alpha expression show enrichment in BA-specific pathway like TGF-beta P53 signaling. Low NI1H4 expression was linked to inflammatory response and TGF-beta signaling. Both groups showed significant activation of the TGF-beta signaling pathway. BA patient classified into two groups based on PPR alpha, NI1H4, and -3 expression. Next, please. Class 2 was higher -3 and low PPR alpha and NI1H4 expression, had higher immune cell inflammation. mRNA and protein level of PPR alpha and FXR in BA patients were lower than in the control group. In conclusion,
Thank you.
In conclusion, our study suggests that the downregulation of PPR alpha and FXR signaling pathway may be closely related to biliary atresia. This finding has significant complications understanding BA's development and potential therapeutic approaches.
Thank you very much. So, any question or comment? No? Okay.
Thank you for clarification. Because I use the SSGSEA analysis to could show that significantly different than class 1.
Thank you very much.
Maestri couldn't make the trip, and I appreciate your help with this. So we're going to talk about a case of retained appendicolith erosion through the gallbladder fundus. The patient is a 15-year-old male who initially presented with 4 days of fever, right lower quadrant abdominal pain, and he had an ultrasound diagnosis of appendicitis revealing a dilated appendix and a 9mm appendicolith. At laparoscopy, the patient had a focal abscess with perforation and an obvious appendicolith that could be seen extruding through the appendix, which was removed along with the appendix. He had stagnant improvement on post-operative day number 7, so he had a CT scan, and you could see on that CT scan, in addition to abscesses along the lower edge of the liver next to the gallbladder, the patient has a second retained appendicolith that was not discovered at the first operation. Next slide. The patient improved and went home, but came back on post-op day 64 with jaundice, fever, and fatigue, with a direct bilirubin of 5.9 and a total bilirubin of 9.7. An ultrasound showed what the radiologist told us was a gallstone in the gallbladder with no biliary dilatation at all. The patient, when admitted, had undergone an ERCP, but there was no stone, and a stent was placed, and the patient did not improve. When they contacted me, I actually suspected that the stone might be next to the gallbladder in the common duct, causing inflammation. However, the radiologists were concerned that the stone was in the gallbladder. We performed laparoscopy, and at surgery, what we found was the omentum densely adherent to the dome of the gallbladder and an opening or an entry into the gallbladder with the fecalith in the gallbladder. There was no inflammation around the common duct. And we actually, in addition to sending the gallbladder pathology, I asked the pathologist to study the stone, and indeed it was fecal matter consistent with the appendicolith that had eroded into the gallbladder. Next slide. In this patient, there was no biliary dilatation. The reason the patient was so jaundiced was from ascending cholangitis from this appendicolith that had eroded into the gallbladder. To our knowledge, this is the first reported case of an appendicolith causing this problem. Certainly there are gallstones that have eroded with gallstone ileus and caused appendiceal obstruction, but this is the first case, to our knowledge, of an appendicolith eroding into the gallbladder. Thank you very much.
Thank you very much. Very, very rare case. So, do you have any question? Yes.
Thank you for your presentation. Did you notify that when you do the appendectomy, you missed the appendicolith?
So the first diagnosis was made with an ultrasound, and you could see on the ultrasound, you could see appendicle lip, but you could also see an appendicle lip at surgery extruding through an obvious opening in the appendix. But the patient must have had a second appendicle lip that I didn't identify at the first surgery.
Okay,
And that was the one that was on CT scan.
Okay, then I want to ask that if the next time, if the same cases occur, you found out that the appendicolis is there, but there is no symptom, then do you do the surgery to remove the appendicolis or just wait?
Only if it's causing problems, which of course in this patient it eventually did, but yeah.
Thank you very much. Okay.
Clinical symptom before and after the surgery. We just begin, but in the future it will be helpful for us to decide the indication or to assess the efficacy of
minus is an extrahepatic duct specific condition about with heterodyne background. We compare the gallbladder phenotypes and the BA symptoms. Here shows the gross anatomical and histological feature of gallbladder and the liver in sonic Hitchcock SOC17 blocks minus and SOC17 blocks minus embryos. Both genotypes exhibit hepatic damage at the peripheral liver and hypoplastic gallbladder. Here shows the morphometric comparison of gallbladder size and liver injury in different genotypes. The gallbladder wise and serum alkaline phosphatase salts as the early cholesterol marker in mass is significantly small and high. The reduction in SOC17 activity correlates with narrower gallbladders as well as increased liver injury. We then conducted correlation analysis between gallbladder parameters and liver injury in the mouse BA model. We observed significant correlations with the width of the gallbladder reflecting the severity of liver injury. Reduced SOC17 expression leads to narrow gallbladder hyperplasia and liver injury. Then we have a new question. How about in human BA? Our research extended to human. We classified BA cases into SOC17 low and other groups in SOC17 expression level at GBH area. And using this classification, we compared gallbladder parameters, patient background, and clinical outcomes. Correlation analysis shows SOC17 low BA cases exhibit a strong correlation between gallbladder width and serum alkaline serum direct bilirubin levels. These findings echoes our observation in the mouse model. There may be contribution of the gallbladder narrow shape to the early pathogenesis in the SOC17 low BA cases. Next, we proceeded to analyze the feature of the SOC17 low and other BA groups. We observed no significant differences in factor without considering the liver transplantation rate. Last, we calculated Kaplan-Meier curves of native liver survival in SOC17 low and other BA. SOC17 low group human BA have better native survival than that of other BA. In conclusion, our research identified a correlation between gallbladder shape and cholestasis in both BA mouse model and human BA with reduced SOC17 expression. SOC17 low BA have better native survival than that of the other BA. This is the result suggests SOC17 low BA is a new subtype associating SOC17 expression in its pathophysiology. Our findings shed light on the role of SOC17 and gallbladder morphology in BA pathophysiology. Morphology. Please. Thank you. ask about the self-17 expression between the body part of gallbladder or bile duct. If is any difference between the part of the bile duct? I assessed the 17 expression at the gallbladder body.
Yama from Japan. I've been told that don't need to read the topic.
Good morning. For screening biliary atresia in Japan, we use a stool color card. Parents check their baby's stool using this card at least 3 times. If the stool color is similar to number 1 to 3 or not similar to number 4 to 7 but becomes closer to number 1 to 3, they should seek medical advice as soon as possible. Unfortunately, this scoring is highly subjective and many disease cases are being missed by SC screening alone. Therefore, we wish to develop an objective, simple, and ultimately less invasive screening method to detect patients with BA during neonatal checkups. For this, we developed the idea that measuring the release of administered indocyanine fluorescence in the stool believed to require circulation through bile to detect the obstruction of the biliary tract in disease such as BA. To this end, we compared healthy rats and obstruction model rats. In these obstruction model rats, the common bile duct was ligated and cut at 2 points near the hepatic portal and papillary region. ICG was administered through the caudal vein, and then the stool from these rats were compared by a fluorescence technique monitoring the period and intensity of fluorescence. These are results from a representative rat of each group with the same stool shown in normal and fluorescent light. A major finding was that in healthy individuals on average at early cut points, the ICG fluorescence was stronger. However, also in the obstruction model rats, there was ICG secretion in the stool, which was weaker and started later, but then decreased more gradually over a longer time period until even 120 hours. This graph summarizes these ICG fluorescence results for all rats investigated. The alignments at 48 and 72 hours shows significant differences between the stool of the healthy and obstruction model groups. In conclusion, we believe our findings suggest that ICG has the potential for initial screening of biliary congestive disease in the neonatal period, which then could be followed up by detailed testing. This study also showed that ICG, somewhat unexpectedly, is excreted into the gastrointestinal tract via route other than the bile duct in a rat model of extrahepatic biliary obstruction. Thank you for listening.
That ICG is going from the liver into the intestine. What do you think it is?
Yeah, so I've done the exact same experiment on human patients, and I found the same result as you had shown in the rats. So the biliary atresia patients, when you give indocyanine green, they still excrete indocyanine green in the stool.
The safety of the RCP in children with uncritical biliary maljunction without obvious bile duct dilatation. Please start.
We have nothing to do. So pancreatic biliary malfunction is characterized by the union of the main pancreatic duct and the common bile duct outside the duodenal wall. So in this study, we focus on the patients which has the length of the common channel is greater than 5 mm and maximum diameter of the common bile duct is less than 10 mm. We call these kind of patients about PBM with no obviously biliary dilation. For this kind of patients, the treatment is controversial because some guideline has suggested that the prophylactic cholecystomy should be done in these kind of patients. But in China, most surgeons think that laparoscopic hepatogenectomy may be the best choice for these kind of patients. Now recently, some paper has just shows that the endoscopic splenectomy may be useful for some kind of patients with choledochal cyst. But if the effect of the EST is effective in the PBM with no biliary dilation patients, is still unclear. This is a retrospective study. Here shows the inclusion and exclusion criteria. All patients enrolled in our study all have the abdominal symptoms. We divided the patients into two groups, ERCP group and the LH group, laparoscopic hepatogenectomy group, according to the surgical methods. Next, please. Here is the preoperative baseline of these two groups. We think the baseline of the two groups is roughly balanced, except the maximum diameter of the common bile duct, which is slightly wider in the laparoscopic hepatogenectomy group. Next, please. Here shows the procedure we have done during operation. We can find the splenectomy. We will do this along this yellow line in the pictures C. Sometimes the ending point of our cut line just reach the middle of the papilla and between the first and second holding folds. Next, please. After operation, we can find that the post-operative recovery between the ERCP and LH group is that the operating time is very shorter in ERCP group, and the time of the recent diet after operation is also shorter, and total length of hospitalization time is shorter in ERCP group. Next. But the biochemical value is also decreased in both groups, but the peak value of the decline has been very higher in the LH group than that in the ERCP group. Next, please. And we have defined the effective treatment as the absence of major post-operative complication and no evidence of significant biliary dilation, cholangitis, or pancreatitis during the follow-up. According to this criteria, the effective rate in the ERCP group is about 45%, but in the LH group is about 85%. We do the verified regression analysis. We find that the length of the common channel in the non-effective group is longer than the effective group. Next, please. So here shows the complication of the ERCP group. The pancreatitis is the most common complication in this group, and 15% of the patients just require a second ERCP surgery. Next, please. Here shows the adverse events in the LH group. Intestinal obstruction is most common in this group. We still have some limitation in our research is that the diagnosis criteria of PBM is different, age may be different, just show in the table 1. And the sensitivity of MRC sometimes is limited. And the last one is the function of the stentor. Sometimes it's difficult to evaluate. So next, please. So in summary, the treatment effect of ERCP is inferior to LH, but definitely ERCP can effectively relieve symptoms for these PBM with no obviously biliary dilation children. How to select the appropriate cases and control length of splenectomy and decide time of conversion are still questions. Thank you for your attention.
Do you recommend this as a first intervention for all these patients and then going on to surgery if unsuccessful? Or you say appropriate, but what are the appropriate patients for this? How do you select it, if there's selection criteria, or do you offer it as the first intervention since it's less invasive for all the patients and then go on to surgery if it fails?
Many thanks for your questions. In our center, choice of this kind of patients, but some of patients just decline the ERCP. They say maybe they have the recurrent symptoms and they cannot accept this. We'll do the laparoscopic hypogenictomy for this kind of patients.
Yes, please. Thank you. What about your opinion about some patients without obvious symptoms, but with just minimum CBD dilatation?
Most of our patients have the abdominal pain and sometimes vomiting, and the cholangitis is the first symptoms of them. If the patients without symptoms, sometimes we cannot find this kind of patients in our hospital. Maybe we don't do anything, but in the guideline of Japan, they recommend the prophylactic cholecystectomy, but it's not accepted in China for most centers. Thank you.
Thank you very much.
Let's move.
Good morning, ladies and gentlemen. I come from China, affiliated hospital of Zhejiang Medical University. Today my topic is study on the diagnostic value of ultrasound, knee function, and laparoscopic subclavian spinal telangiectasis signs for cranial trigger. Cranial trigger is characterized by the present jaundice at hospital and the progress lead fibrosis. Its origin is unclear. The early diagnosis of disease is particularly important to inform the progresses. The definite diagnosis of BA is made by intrahepatic cholangiography and knee biopsy. Due to the invasiveness of the procedure and the need to the inclusion, IOC is not readily accepted by the patient family, leading to a delay in diagnosis. During the procedure of operation, multiple hepatic subclavian spinal telangiectasis lesion followed HSCT sign are variable in BA patients. The HSCT sign was defined as the presence of 3 or more bronchs in the large spinal vascular plaques distributed on the knee surface and decentrated and concentrated in the knee surface. This is the HSCT sign. In this study, we evaluated HSCT sign using diagnostic laparoscopic in BA patients and those with other cause of the cholangitis jaundice. We also compared with the biochemical test, knee ultrasound finding knee stiffness value and IOC. Result, this compare of the patient characteristics between the BA and the non-BA. We can see the gamma GGT and the knee stiffness value and the abnormal blood and the HSC sign was significant difference. And this is difference in diagnosis occurrence of various partners. When the cutoff the DBLA was 1817.9. Gamma GGT, the cutoff is 182. Knee stiffness value, knee stiffness value is 6.4 kPa. This is the laparoscopic value of the knee surface in BA. We can see the HST in the knee surface, but the diagrammatic of the surface is more than the others. This year we also check the knee. For example, the cholangiography and the other we can see the HSTTC. Laparoscopic, I will say, is confirm the diagnosis of BA before performing calcium operation. Recently, we noticed that almost all children with BA had HSACT sign on laparoscopic exploring of the knee surface. Due to the significant difference in the gamma-GBT cutoff value and no sensitivity, it cannot be used to definitive diagnosis of BA, but it certainly helps to suspecting BA in newborns. In this study, we found that the AUC of knee stiffness value more than 6.4 kPa for diagnosing BA was 96%, and the sensitivity and the specificity were 89.8% and 95%. Respectively, this finding indicates that knee stenosis better than gamma-GBT and ultrasound for the diagnosis of BA. In order to reduce the risk of complicating the diagnostic BA efficiently, the HSA can be used as a good diagnostic value with the sensitivity of 100. We think that most important for options HSTTC might be related to reported hypertension and the hypertrophic of the hyperplastic change of arteriograms. Lateral HSCT sign has several advantages. First, laparoscopic is common in almost all hospitals and simple laparoscopy. Second, it is easy to perform and can be done faster than IOC, which shortens the operation time. Third, diagnostic laparoscopic HSCT sign is a minimally invasive procedure. In summary, the detection of the HSCT sign, the laparoscopic has high accuracy for the diagnosis of BA with sensitivity and specificity of 100%. The HSCT sign may be used as an alternative to IOC, and the radiation exposed to the infant can be avoided. Thank you very much.
Thank you. Only allow the one question.
Thank you. Especially from Hong Kong. Just wonder, you said the telangiectasia is related to portal retention. So I suppose portal retention takes time to develop. So can this telangiectasia be used for early diagnosis in BACC?
Yes, if we want to diagnosis early, so I think the laparoscopic is necessary. And we can see the.
So what is the median age for diagnosis?
40 days. Yes, the 40 days.
Thank you.
Thank you.
Thanks so much. Let's move on to the last speaker from Series Institution, the experience of 2 years before.
For several hospitals South Korea. Today I'd like to talk about surgical management of pancreatic neoplasm in children, a single institution experience over 15 years. The pancreatic neoplasm in children are very rare. In children, the pancreatic neoplasm is generally asymptomatic and incidental finding beyond medical examination. There are very few data in the current literature regarding short and long-term outcome for children. The aim of this study to review our experience in the management of pancreatic neoplasm in children. With retrospective analysis, the clinical data of 28 patients underwent treatment for pancreatic neoplasm in our institution. The study period was 15 years. The surgical outcome and postoperative height and weight development was analyzed. The female sex was predominant. The median age was 11 years. Median tumor size was 16.58 centimeters. The main presenting symptom was abdominal pain and followed by incidental finding, abdominal mass, vomiting, pancreatitis, weight loss, bleeding, and hypoglycemia. The location of tumor has shown head in 4 cases, body 7 cases, tail 6 cases, and diffusion in 1 case. The neoadjuvant chemotherapy was performed on 1 patient with pancreatoblastoma. In final history diagnosis, the benign tumor was 17%, borderline was 71%, and malignant tumor was 10%. The historic diagnosis of benign tumor was mucinous cyst, osteoblastocyst, pseudocyst, benign cyst, each one case. The borderline tumor was a solid pseudopapular myoplastic 20 case, and malignant tumor was pancreatoblastoma, pseudopapillary carcinoma, and malignous phagocytomas in each one case. The median follow-up period was 5.9 years. The surgical procedure and outcome were analyzed according to tumor location. The median tumor size was not significantly different on each location. The extent of the surgical resection of head location was performed PPPD 2 case, central pancreatectomy 1 case, and enucleation 1 case. In body location was performed distal pancreatectomy 6 case, central pancreatectomy 1 case. In tail location was performed distal pancreatectomy 16 case. The postoperative complication was shown 1 case required reoperation due to postoperative pancreatic fistula for enucleation in head location, and other POPF grade B occurred 3 cases in head location and each 1 case in body and tail. This patient needs drainage for fluid correction. Next, please. A total 4 case tumor rupture event occurred in SPM patient. 1 case during a preoperative, 3 cases during operation. 1 patient had mortality due to postoperative bleeding. This patient's final diagnosis was malignant phagocytoma. During follow-up, in 4 cases of tumor rupture event in SPM patient have recurrence in 2 cases. In addition, the solid pseudopapillary carcinoma patient has metastatic recurrence, and the patient under liver transplantation had 5-year pancreatectomy. Adjuvant chemotherapy was admission to 6 patients. 6 patients with pancreatoblastoma, solid pseudopapillary carcinoma, and SPM. After surgery, and there was no mortality during follow-up. The patient weight and height was not significantly impacted after operation. In our series, benign and borderline histology diagnosis was dominant, and variant extent surgical resection was performed. Next, please. Next. The surgical treatment for pediatric pancreatitis seemed to be safe and effective. Thank you.
And do you have any patients who had a left-sided prototypization at diagnosis?
No. No every patient. Some patients need to pancreatectomy with splenectomy together.
Thank you very much.
Is the route assist surgery, and what is the advantage?
Some patients do the enucleation or to the to clear margins, and the minimal receiver surgery can perform. So we assess the robotic surgery.
Thank you for the presentation. Finished sessions, oncologists, and Patrick Zhou from Hong Kong, your moderators. And next to me is Dr. Kai Li from Children's Hospital of Fudan University. So now may I ask the first speakers, Dr. Wei Dong, to come to the podium and to talk about single cell profiles delineation tumor cell lineages in pediatric hepatoblastoma, suggesting therapeutic targets. Please.
About the hepatoblastoma. My topic about the single cell profile, my tumor cell lineages in pediatric hepatoblastoma, suggesting therapeutic targets. Hepatoblastoma is the most common liver cancer. in young children with diverse historic subtypes that are thought to be associated with developmental backgrounds. So about the identifying hyperplasma cell subtypes and their links to the cell of origin, the method thinking. So we designed this study and want to research the biological behavior of hyperplasma, and we designed human cell lines and identifying potential therapeutic targets for the developmental of new treatment strategies. In order to for the new results, we designed this study. We designed 3 cohorts. The first cohort, we collected 32 patients, including 37 samples from tumor, and we collected the stem cell and detect the stem cell on sequence. And we use bioinformation analysis and display human and to find some new cell structure. And the second cohort, we use the HE or HC to validate our results from the first cohort. And we combine the HEC cells and MBC cells. And the third cohort, we use the PDN model from 2 patients. We use the wanted to detect some pharmaceutical research, and we defined 4 groups about repeat, APT, and regular control C5. Our results from the same cell analysis found that hyperplasma cells contained different subpopulations and exhibit vertical and maximal characters sector, and each stress is highly similar to the circular phenotype of early hyperplasma. In order to validate our results, we download from the published data from the 3 papers, including non-screened paper and one and from Wilson. I download this data and single cell data, and we compare with our results. From this result, we found that each structure is highly similar to the circular phenotype of early hyperplasma. And next, we compared pre-chemotherapy and post-chemotherapy. And from compared from that, the proportion of MBC cells reduced after chemotherapy, while AGC cluster we reached after chemotherapy. And the pathway analysis found that pathways associated with product systems were reached in post-chemotherapy AGC cells. And then we use AGE and AGC to validate our results from the first and the second cohort. And we found that where our results revealed that the histological features of EC cells and MT cells in independent cohorts, including 105 patients. And we observed that the 2 subtypes of embryonal tumors focusing and feature of AFP and VM markers, and identified with and small cell undifferentiated cell types. And we compared analyzed the communication between tumor cells and most macroenvironmental cell types. From analysis, we found that the communication was enhanced after chemotherapy. From this feature, next slide, for example, a yellow line. If the yellow line is more sync, means the communication is more enhanced. If the line is same, means the communication is more. And we did cell culture. We found that FGFR was selectively present in MBC culture, but the FGFR4 and other markers, HFR and ERB3 was present in HEC culture. The difference has our different markers. And last, we use data models. I wanted to detect the difference from the state. So we conduct the data models and experiment, and we found that the highly proliferative EC cells of for hyperplasma can title using FGFR inhibitor and named Rivitin. For this feature website, we designed the focus, and if we use the Rivitin and C5-way chemotherapy, we found that the tumor size is getting more smaller. Our conclusion, we provide a large-scale single-cell transcriptional analysis of human papilloma, and we identified two major malignant subtypes for which we test AP and Max. If AP Max silent means maybe this titer is AT cells. If subtitle has a titer VM, which is titer is MC titer. And the two subtypes of tumor cells should high similar to the cell population of germ hepatitis. And we found that preoperative chemotherapy may introduce the translation of MCD cells towards hepatic states and AC cells or more resistant to chemotherapy, and may contribute to tumor regress of the chemotherapy. And we found that HEG cells and MBC cells have distinct operational pattern, and we found that FGFR single maybe repeating maybe serve as a therapeutic target of highly productive of BC cells. Thank you for your attention.
Hajime from Japan. Yeah, very interesting, challenging. My question is negative sense.
Thank you for coming to the question. At the maybe and from the paper, we found that the contamination is not high from the paper. Maybe some different of some different people. So we can show this, please. Thank you.
Thank you, Dr. So let's move to the.
Good morning, ladies and gentlemen. I'm Lin Weihong, come from Children's Hospital of Fudan University. Today is my great honor to be here to share my study data. Downregulation of fast allergy correlates with formation of immunosuppressive tumor microenvironment in neuroblastoma via so-called RNA TBC1D4 microRNA 21 axis. Immunotherapy, such as immune checkpoint blockade, is widely used in the treatment of various tumors. However, neuroblastoma, usually with low immunogenicity, responds poorly to the immunotherapy, probably due to the formation of an immunosuppressive tumor microenvironment. So, it is of great significance to elucidate the mechanism underlying ICD response in neuroblastoma. In our previous study, we found that microRNA 21 was usually upregulated in neuroblastoma. The upregulation of microRNA 21 correlated with poor prognosis. So, to discover microRNA 21 related regulatory pathway, we aim to identify circRNAs that may serve as microRNA sponge to inhibit microRNA 21 and the downstream mRNA targets degraded by microRNA 21. First, using circRNA sequence, we identify the dysregulated circRNAs in neuroblastoma samples. And then, using radar, we predict 16 circRNAs that may bind to microRNA 21 in neuroblastoma samples. And we further verify that circRNA TBC1D4, circRNA LAB2, and circRNA TCFBR3 were significantly downregulated in neuroblastoma samples. And of these three circRNAs, compared to the other two, the predicted binding sequence of circRNA TBC1D4 is completely complementary with the sequence of microRNA 21. So we choose circle RNA TBC1D4 for further verification. And dual luciferase reporter system assays verify that circle RNA TBC1D4 could bind to microRNA 21. And then, using MIA database, we predict the top 10 downstream targets of microRNA 21. And we further verify that of these 10 targets, fast allergy was upregulated in neuroblastoma cells with circle RNA TBC1D4 overexpressions. Fast allergy, also called fast ligand, is a member of the tumor necrosis factor superfamily, and the fast allergy signal pathway is essential for immune system regulation. So, a series of bioinformatic analyses were conducted to verify whether fast allergy play a role in the regulation of tumor immunity in neuroblastoma. First, using R2 database, the survival analysis showed that neuroblastoma with high expression fast allergy had a higher overall survival probability. And GSE analysis showed that the top 10 enriched gene sets in neuroblastoma with high expression fast allergy were mainly about tumor immunity. It has been reported that the therapeutic effect of ICB is related with tumor-infiltrated immune cells and the expression level of PD-L1 and HLA1. And the analysis of tumor-infiltrating immune cells using cyber-shot showed that neuroblastoma with low expression fast allergy had fewer immune cells infiltrated, such as B cell, CD4 positive T cell, CD8 positive T cell, and pro-inflammatory type 1 macrophage. And inversely, the infiltration of the immunosuppressive type 2 macrophage is increased. We also find the co-expression analysis also found that the expression level of fast allergy was strongly related with the expression of CD274, which encoding PD-L1. At the same, we also find the expression level of fast allergy was strongly related with the expression of HLA1, including the A, B, C types. So, in conclusion, first we found that circle RNA TBC1D4 was frequently downregulated in neuroblastoma, resulting in attenuated inhibition of microRNA 21, therefore downregulated fast allergy. Second, we found downregulation of fast allergy correlated with poor prognosis and formation of immunosuppressive tumor microenvironment, indicating that those neuroblastoma patients with high fast allergy expression might benefit from the treatment of ICB. That's all. Thank you for your attention.
Please.
So in vivo situation, how do you get the circle RNA into the tumor? What would be a one way to do that?
The circle RNA sequence is our patient, and the bioinformatic analysis is from the Paps database. Circle RNA. Excuse me, you mean?
How do you deliver the circle RNA to the tumor?
To a tumor. Lentiviral, in the method of lentiviral. Thank you.
This is a predict axis by bioinformatics. So I think it will be the further study to do the cell experiment or the animal experiment to verify this axis. Okay, thank you.
Thank you. Our next speaker is Dr. Shishir Fumino from Kyoto, Japan.
And he will talk about the results from a Japan nationwide survey of long-term outcomes of infantile sacral procedural teratoma. Please.
Good morning, ladies and gentlemen. Sacrocochlear teratoma is an uncommon extracorneal junctional tumor during childhood. Even after successful tumor resection, some patients presented with functional sequelae and tumor recurrence. In this study, we conducted multicentric comfort of SCT to clarify Japanese trends in SCT sequelae. So a paper-based questionnaire survey was performed to the facilities accredited by Japanese Society of Pediatric Surgeons. The inclusion criteria was the patient who underwent radical surgery at less than 1 year old and who survived for at least 180 days after birth during the 20-year period from 2000 to 2019. And survey items are shown here. Concerning follow-up, bowel function was categorized into 5 parameters, urinary function into 5 parameters, and lower leg function into 3 parameters. The category score over 1 was defined as having these functions, and the information of tumor recurrence were also investigated. And finally, a total of 355 patients were included in the analysis. Around 45% patients were diagnosed prenatally, and the median maximum tumor diameter was 6.1 centimeter. Outcome classification was type 1 in 50%, type 2 in 20%, type 3 in 10%, and type 4 in 3%. The pathology of the initial tumor was mature teratoma in 76%, immature teratoma in 20%, and malignancy in 3%. And regarding the extent of excision, total resection was performed in 92%, subtotal resection was in 6%, and partial resection in 1%. The median follow-up period after birth was 6.6 years, and 18% of patients had erectile dysfunction, 30% had urologic dysfunction, and 3% had lower extremity motor dysfunction. Recurrence of tumor was noted in 42 patients, 12%, and age at recurrence was 16.8 months. Out of 42 patients, 22 patients had malignant recurrence with elevated serum AFP levels. And the Venn diagram showed functional sequelae overlapping. Finally, 83 cases, 23.4% has post-operative dysfunction, and 40% of them are overlapping. In the logistic regression test, premature birth, low birth weight, presence of prenatal diagnosis, maximum tumor diameter over 10 centimeter, Altman's classification type 3 and 4, incomplete tumor resection, and surgical complications were significant risk factors. And as for tumor recurrence, immature or malignancy pathology and incomplete resection and surgical complications were significant risk factors. So 23.4% had post-operative functional sequelae in this study, and overlapped in 40%. Functional sequelae are complex complications with possible common causes, such as myogenic and/or neurogenic impairment due to compression of large tumor, and surgical damage to pelvic organs and pelvic floor muscles. There was a report showing no significant difference in functional disorders between adults with SCT and control group. So it is important to recognize long-term complications and ensure careful and regular follow-up. And such symptoms can be ameliorated during follow-up. 11.8% presented tumor recurrence in this study. And median age at occurrence of 1 year old 0 to 12, and 6.2% showed malignancy with a median age of 1 year old 0 to 3. So to eliminate chances of tumor recurrence, the physicians should make an effort to perform complete surgical resection without surgical complications, and regular and careful follow-up are mandatory, and regular measurement of serum AFP during at least 3 years after treatment is recommended. This is the limitation of this study, and this is the conclusions. Thank you for your attention. Terima kasih.
Thank you. And this speech is open for questions and comments.
Just a thought weight that you remove when you remove the sacral conjugal peritoneum. Because if you take out half the body weight, so I've had one 3 kilogram child reduced to 1,600 grams. And that's going to be very different from one where it's only 10% of the body weight. It might be worthwhile reviewing that statistic.
Yes, in this study, the range of body weight was around 2 kilograms to 4 kilograms. So
no, but it's the body weight before and after surgery.
We have no data soon.
Yeah. One up to 3 months. So maybe you have to notice that and to follow up after with the time to see the result after the operation, early and late sequence. Okay.
Yes. I cannot catch it. So what is the point?
I say that's some dysfunction as a sequence.
Thank you very much for the opportunity to present our work. Liver regeneration follows loss of functional liver volume, with one of the stimuli being hepatectomy. However, there is scarce information regarding liver regeneration with children with hepatoblastoma following treatment. The objective of our study was to evaluate the extent of liver regeneration compared to the appropriate volume for weight in children with hepatoblastoma after chemotherapy and hepatectomy. A database of patients from 3 tertiary hospitals in Malaysia offering both pediatric surgery as well as pediatric oncology services was created. This comprised of patients treated for hepatoblastoma between the 1st of January 2018 to the 31st of December 2021. A total of 36 patients were recruited into our study. Demographic data, chemotherapy regime, the type of surgical resection performed was tabulated, and the liver volume for weight was calculated using the NODA formula. CT liver volumetry was performed by a radiologist who was blinded to the treatment regime, and subsequently data analysis was performed. Our results: 20 of our patients were female, 16 were male. Chemotherapy was administered according to the SIAPOL protocol, and 22 patients received high-risk chemotherapy, 14 patients received standard-risk chemotherapy. Liver regeneration of 100% or more was observed in the high-risk group. A liver regeneration of 80% or more was observed, even in the high-risk group and the standard-risk group. Biochemical data was examined as well. Alpha-fetoprotein showed a decline throughout the course of the treatment. ALT levels perioperatively were normal. At 48 hours post-operatively, ALT levels rose, but by the completion of treatment, CT ALT levels were normal. Total bilirubin levels were also normal preoperatively, rose at 48 hours post-op, and progressively normalized and were completely normal at the completion of treatment CT. Albumin levels were normal preoperatively, dropped at 48 hours post-operatively, and were normal at the end of treatment. Our study shows that children with hepatoblastoma are able to regenerate their livers to at least 80% of the expected volume for weight following both chemotherapy and hepatectomy. The lowest percentage of regeneration in our cohort was 80% of the expected volume for weight, with a minimum of 20 to 30% being required for liver function homeostasis. This shows that repeated liver resections may be feasible in these children should they be necessitated. Other factors we should consider are the duration of the Pringles maneuver, duration of total hepatic vascular isolation, and presence of lactic acidosis intraoperatively. However, this was beyond the scope of our study as some of these parameters were not readily available. Limitations of our study. This was a retrospective study with a small sample size of 36. Prospective studies in which more factors could be considered would likely yield more clinically relevant data. In conclusion, children with hepatoblastoma have excellent potential for liver regeneration regardless of the chemotherapy regime and the type of hepatic resection performed. We are then perhaps able to counsel parents more effectively preoperatively and allay some of the fear and anxiety that is associated with the disease. Thank you.
And there is another question. So may I ask, usually, what's the percentage of liver remnants that you would accept for liver resection rather than liver transplant? And in this, after this study, would you be more aggressive in performing liver resection?
Usually a minimum of 20 to 30% is required for liver homeostasis. From our cohort of patients, we can perform various types of resections, including extended right, left hepatectomy, left lateral, and several surgeries which included formal resection plus a segmentectomy. None of our patients had post-operative liver failure. None of them had insufficient liver remnant. Whether we would be more aggressive or not.
Since you know liver will regenerate, can I say, would you accept like lower percentage, 15?
If I could, for hepatoblastoma, it's something that we're exploring, and that really depends on how developed our transplantation program becomes in the next few years.
Thank you. Thank you very much. No more questions?
Good morning, everyone. Patients who receive intensive treatment for neuroblastoma may exhibit ectatic growth of the abdominal aorta. The aim of this study was to evaluate the abdominal aortic diameter in high-risk neuroblastoma patients and determine the risk of aortic narrowing after intensive treatment. The study group included 35 patients with high-risk abdominal neuroblastoma, while the control group consisted of 56 children with non-oncologic disorders. We digitally measured the aortic diameter for specific levels of abdominal aorta shown on the slide. We used regression analysis of age and aortic diameter to determine the regression formula for each level in each group. This slide shows the effect of treatment on the aortic diameter. First, we established a normal control reference values for each level of aortic diameter by measuring the aortic diameter of the control group. Scatter plots and linear regression lines comparing aortic diameter and age at each aortic level as shown on the slide. The gray lines show the control group. To determine whether any treatment for neuroblastoma has an effect on the aortic diameter, we first compared the aortic diameter before treatment to those evaluated at any time point after administration of any treatment. The aortic diameter presenting neuroblastoma patients was not significantly different from the control group. Contrarily, after receiving any treatment, the aortic diameter was significantly smaller in the neuroblastoma group. Then, we assess the surgical and radiotherapy treatments as a risk factor of impaired aortic growth. To our interest, when we look at the extent of surgical resection, cases undergoing rough total resection, shown in blue, showed a significantly smaller aortic diameters compared to the control group in gray, whereas cases receiving subtotal resection in red did not show any difference. Next, we compared the effect of external beam radiotherapy, EBRT, and intraoperative radiotherapy, IORT. Patients treated with EBRT had significantly smaller aortic diameters than the control at all aortic level except for the celiac axis, and patients treated with IORT had significantly smaller aortic diameters than the controls at all aortic levels. In conclusion, patients with neuroblastoma may experience impaired development of the abdominal aorta after multimodal therapy. Close observation and long-term follow-up are essential to monitor for severe vascular complications. Thank you.
Are there any questions or comments?
Thank you for very interesting studies. I have a question about any symptom, clinical symptom that you follow up based on this study, like significant ischemic or some renal failure or something.
Yes, thank you for your question. And some patients showed several symptoms of severe mid-aortic syndrome, like ischemic colitis and the numbing of hypertension and something like that.
Yeah, were there patients dominant in external radiation therapy groups as well?
Yes, as well.
Thank you so much.
May I ask a question? I noticed that you do the intraoperative.
In 2008, since then, we did not perform IORT, but for the kind of that doesn't exist.
Thank you.
Sorry.
Good morning, everyone. My name is Tom Cho, I'm from West China Hospital of Fujian University. Today it's my great honor to talk about composite-form hemangioma with bone destruction, a 50-year follow-up cohort study. My presentation will be divided into 4 parts. First, composite-form hemangioma is a rare, locally aggressive vascular tumor that often occurs in infants and young children. And the goal of our study was to analyze the clinical characteristics of aged patients with bone destruction. And then we move to the methods. Our study was a descriptive cohort study with follow-up from 2007 to 2023. And the definition, this is the definition of our decreased range of motion, intracompartmental, extracompartmental, and PMP. And then the results, we included about 268 people in our study, and we divided patients into 2 groups with bone destruction and without bone destruction. And the results showed that the median age at diagnosis of patients with bone destruction was much later than that of patients without bone destruction. And patients with bone destruction were more likely to have a decreased range of motion. and then we did the subgroup analysis, and we found that metaphysis involvement was more likely to occur in the lower limb bones, and the lower limb bones were more likely to be associated with decreased range of motion. And then another subtype is intra-compartmental and extra-compartmental. We found that tumors involving extra-compartmental bone were more likely to have decreased range of motion and exhibit the KMP. This picture showed the whole body distribution of bone destruction in KHE patients. And this picture showed a 2-year-old male patient with KHE of the left distal femur. And we can see the MRI picture showed after the single sirolimus treatment, the 6 months and 12 months, 18 months and 24 months treatment. So we get to the conclusion that due to the delay in injection, we should be concerned about the prognosis of patients with bone KHE, and we should pay more attention to the patients involving extra-compartmental bone and lower limb bones. And we should also give full play to the role of multidisciplinary teams and to reduce the long-term complications of KHE with bone destruction and improve the quality of life of patients. That's all for my presentation. Thank you for your listening.
Is there any question or comment?
Thank you for your presentation.
We should treat the sirolimus with prednisolone, and with the patients with KHE without KMP, and we treat it with single sirolimus. Maybe this is a retrospective study, and this is the bias of our study, and we will do some prospective study in the future. Thank you.
Good morning. Just a few announcements. For the next session, we'll start scheduled at 10 to 10, so we're going to have an extended break because some presenters seem to be able to arrive in Bali, so they haven't told us about it. So that's quite a few missing presentations. Secondly, tonight's bus leaves at 5:30 to the conference venue, and you have to meet at the lobby to catch a bus. The very last one will probably leave about 6, and it takes about half an hour to get to the venue with police escort. I'm not sure without how long it will take. And the bus will come back after the sing-off. So every country, whether you are 1 or 10 or 100, will have to sing a song of less than 4 minutes in duration, one song only, in alphabetical order or in whichever order John prefers. And the bus there will be one bus accommodating 35 passengers leaving at 9 p.m. Probably priorities will be given to young children, families with young children. But if you are the only one for the country, please do not escape from the conference. And all the rest of the buses will leave after the sing-off finishes. Right?
Which is great. We have somewhere in the high 20s, the number of countries. And yes, exactly like you said, whether it's 1 or 100, you're gonna sing. So be ready, and we'll try to make this a lot of fun. Please have your AV available as well so that we can have it uploaded early in the evening before your performance starts, so we can just make everything move along. So please tell your teams 4 minutes will be the limit. Thank you.
Thank you, John. So we'll come back at 10 to 10 for the next session.
Serio?
Sang-san is going to talk about endoscopic management of duodenal obstruction.
Sang-san from Children's Hospital of Fudan University. It's my honor to share our experience about clinical application of endoscopic diaphragmotomy and dilation in congenital duodenal diaphragm. Congenital duodenal diaphragm is a rare cause of duodenal obstruction in infants and children, with an incidence of 1 in 5 to 5,000 to 10,000. The present approach to treatment is surgical intervention by either excision and duodenoplasty or with bypass via duodenal ostomy, which is invasive and has the risk of anastomotic leakage and peritoneal infection. Endoscopic treatment was firstly reported by a Swiss surgeon, Gersh, in 1984. He treated adult patient by endoscopic laser ablation. Since endoscopic equipment and instrument has been markedly improved, endoscopic surgery can be performed more easily and safely, even in infants and children. Over the past 40 years, a total of about 40 patients treated by endoscopy were reported all over the world. The reported methods include laser ablation, volume dilation, incision with a high-frequency electrotome such as hook knives, or combining with balloon dilation with electrotome incision. Balloon dilation and electrotome incision was the commonest method in the reported cases, which is also the method in this study. Incision with papillotome or partial excision with snare were also reported in elective cases. So the objective of this study was to summarize the key point of differential diagnosis and treatment of CDD under endoscopy, and to evaluate the efficiency and safety of endoscopic treatment of CDD. A total of 13 cases of duodenal obstruction were tried to treat it by endoscopy. 10 were confirmed to be duodenal diaphragm, and 3 were verified to be annular pancreas. The age at operation was ranged from 15 days to 7 years, with a median age of 2.25 years old. The weight at operation was 2.85 to 22 kilograms. 2 of the 10 patients had previous surgery. The diagram was incised and dilated in 7 patients and just incised in 3 patients. This is a week of the operation. You can see its movement upon suction or infusion of the air. Then a guideline was inserted through the openings, and the diaphragm was incised by a hook knife and dilated by a balloon. The picture on the right side are the UTI before and after the operation. Various gastroscopic features of duodenal diaphragm are shown in these pictures. Picture A shows a diaphragm with well-defined openings, and B shows a diaphragm with a mucosal failure. Dome-shaped structure can be seen during inspiration, and the edge of the diaphragm can be judged according to the boundary of the dome structure. 11 endoscopic operations were performed in 10 patients. Time of the operation was 15 to 55 minutes. All diaphragm was successfully incised or dilated to a diameter more than 1 centimeter. No complications such as bleeding, pneumoperitoneum, and duodenal papillary injury during the operation. Liquid diet was started in 24 hours after surgery, and full oral feeding were resumed within 3 to 5 days. No prophylactic antibiotics were used after the operation. Three older children complained of abdominal pain within 72 hours. No other children or family members complained of discomfort. NG tube were placed in 4 patients, and all were removed within 1 week. 3 of the 7 tested had transient amylase elevation after surgery, which decreased to normal within 72 hours. No duodenal obstruction-related vomiting occurred during the follow-up period. 3 showed recurrence of stenosis in UTI, 1 of which underwent partial diaphragm resection again 2 months after the primary treatment. The conclusion of this study, endoscopic diaphragmotomy and balloon dilation are safe and effective, which can be a new option for minimal invasive treatment of CDD. Recurrent duodenal stenosis may be the main postoperative complication. More cases and longer follow-up are needed to verify the efficiency and safety of this approach. Thank you.
Thank you, Dr. Sun. The paper is open for discussion. Let me start with asking.
Identify the course of the common duct that usually runs within the diaphragm.
It's a very, the picture A and picture 2 is a very typical diaphragm appearance. Usually the openings is near the inner wall of the duodenum. So when we incise, we usually incise to the outside of the inner wall. It's usually very safe.
So you never actually identified it, you just hoped it wasn't there. You never actually identified the duodenal, you just gambled that it wasn't running in that space.
Yes.
Yeah.
One more question.
Greeting everyone. I'm very glad to be here and have this opportunity to attend this meeting. My name is Yu Jia. I come from China. I work at the Screening Central Hospital and I started in Trinity Medical University with guiding of Professor Yuan Mei. It's lucky for me to be the first time today to share the topic overexpression of MT3 enhances epithelial malignant translation by Rakhwan-Jenke pathway in Hirschsprung disease. My presentation will include these 4 parts. First, background. Wait for a minute. Hirschsprung disease SHCR is a developmental disorder of the enteric nervous system in which the enteric ganglia are defective due to the reduced cell proliferation and migration of neural crystal cells in the embryonic period. Before migration, the neural crystal cells must undergo epithelial malignant transition (EMT), and we found that differential expression of MT3 in the intestinal tissues of HCR by screening using a Q expression profiling chip. And we also found that MT3 expression is down-regulated in HCR. However, we don't know whether MT3 affects the neural EMT process and in that way. So that's the reason I researched it. The methods. First, the qPCR and Western blotting were used to assess the expression of MT3, Rakhwan-Jenke, and the EMT markers in 40 SHCR patients. Then the fish examination were used to assess the subcellular localization of MT3 in the colon tissues. Then we further explore the result of MT3 in Hirschsprung disease in vivo. The results. The expression of M3, Rackham, JK, Catherine, and Wilmington was decreased in symptomatic column. However, the E Catherine was increased in this part. The fish examination showed that MT3 was both in cytoplasm and nucleus, but merely enriched in the cytoplasm. Look at these red arrows. MT3 overexpression promoted cell migration and proliferation, but the apoptosis of cells was not affected. We predicted the target relationship of M3 and Rackham by NCBI, and the luciferase reporters say confirmed the target relationship of these in 293 T cells. We found that overexpression of M3 promoted the EMT process of cells. Meanwhile, it promoted the integration of Rackham and JK. However, the expression of a signaling pathway potentials after aiding inhibitors like 1A116 and SP 8600125. Next, we also found that the proliferation and migration of cells was decreased after aiding the inhibitors. Interestingly, the EMT markers are were also changed. The last part, we get conclusion. We found that low expression of MT3 possibly plays an essential role in the development of SHCR by inhibiting cell migration, proliferation, and the EMT process, while the Rackham-JK signaling pathway. The limitations of this research: first, SHSY5Y cells as a similar model for SHCR research don't simulate the pathogenesis of SHCR well. Second, we don't have research in vivo. That's all. Thanks for your attention. Any questions?
Thanks, Dr. Yin. Questions?
The cell line that you use, SH, is it?
Your question. Excuse me, I will have to translate. Because I'm sorry, I can't speak Chinese.
That's all right. I've got a question. Hopefully, you'll be able to answer this. You used the segments that were from the either anastomosis or that had strictured. Have you looked at areas from your initial pull-through, so where the tissue that's at the first operation? Have you been able to look at those tissues?
要不你先用中文解释一下为什么使用神经细胞系？
直接用中文 OK。I'm so sorry。首先是因为就是这个细胞系呢是就是常规用于研究先天巨叶长的一个细胞系，然后呢就是目前这个神经棘细胞是研究这个呢，然后因为它提取比较困难，所以我们就选择了是 SHSY5Y cells。
So excisional trends are usually used to find the relationships with that disease. So in this case, they use that cell line to discover the EMT transition and also the migration of the neural cells. In other cases, it's quite difficult to find and extract the neural cells from the tissues. So they use the neuroblastoma cell lines to do this research.
Okay. Thank you very much. Thanks, Dr. Yin.
Thank you.
Thank you for the opportunity to present today. My name is Nick. I'm one of the investigators on the topic. we have no disclosures. So pilonidal sinus disease is a chronic inflammatory condition that affects predominantly teenagers and young adults. While there's a great deal of variation in current treatment, the current gold standard is excision with primary off-midline closure, one of those techniques being the Karadukas procedure. Whilst it is a very successful technique, it is fraught with complications, and that being namely surgical wound dehiscence, which can occur in up to 44% of cases. Negative pressure wound therapy has been found to improve wound healing in excisions healed by secondary intention, but there's no research looking at it to improve wound healing in wounds healed by primary intention. Our aim is to evaluate whether a negative pressure dressing, being a snap dressing in this case, would improve the rates of wound dehiscence in comparison to a conventional passive dressing. We also looked at the time taken for the wound to fully heal, the analgesia requirements post-operatively, patient quality of life, and time taken to resume normal activities. We performed a prospective randomised controlled trial that was crossover between paediatric and adult because we feel that it's the same disease process and it predominantly affects teenagers, so therefore we could get greater numbers for our study. We performed this study between 2018 and 2023. The recruitment during this time was affected by the COVID-19 pandemic, which didn't allow category 2 and 3 elective procedures to occur during that time. Our study occurred at 4 tertiary hospitals within a single health service. Our study was powered to 84 patients at the 5% significance level, and we performed an interim analysis at 50 patients. And at the time of this analysis, we found that no further recruitment would be necessary as it wouldn't change the results. We performed an intention to treat analysis. Our inclusion criteria were any patients aged 12 to 40 years undergoing elective excision of pilonidal disease with off-midline primary closure. We excluded any patient outside of this age range and also wanted people that had significant medical comorbidity that would affect wound healing. We also exclude patients with disease close to the anal verge, as this would affect our ability to get a seal on the dressings that we were using. So we recruited patients as described, and they were randomised using a computer. Intraoperatively, surgeons were blinded to the randomisation until the time of skin closure, that skin closure had been completed. Patients were randomised to receive either a snap dressing, which was determined as per institutional practice, or a conventional passive dressing, which was an oxide or primacore dressing, which was also decided in consultation with the surgeons involved. Patients were followed up for the first week regularly by hospital in the home, then at the 2-week mark in the clinic, and weekly until the time of wound healing, and then with a phone call at 8 weeks' time. We recruited 50 patients in total, as mentioned at our interim analysis, and 30% of our population were aged under 18 years. As expected, the majority were male. There was a mean age of 22 years and a mean BMI of 26. Our primary finding was that negative pressure dressings did not reduce the rate of wound dehiscence compared to passive dressings. Our total dehiscence rate was 42%, though this would also include any minor skin breakdown. So we subdivided it into clinically significant dehiscence of greater than 5 millimetres, which was 20%, and this is in keeping with the literature. We found that with a p-value of 0.6, there was no additional benefit to using negative pressure dressings. Within the paediatric subset, which we defined as patients aged under 18, we found again that there was no difference and no benefit to using a negative pressure dressing to prevent wound dehiscence. And again, you can see there that the p-values are the same as with all patients. Negative pressure dressing also didn't improve the time to wound healing, which for all patients was on average about 22 days. It didn't improve analgesia utilisation post-operatively, and it also didn't improve time to return to normal activities or to return to school to work, which again for all patients occurred between 20 and 30 days post-operatively. We found that there was a significant additional cost to the use of negative pressure dressings. So at the time of our study, a snap dressing cost 235 Australian dollars, whereas a passive dressing cost less than $1. So in conclusion, we found that a negative pressure dressing in comparison to a passive dressing had no additional benefit in terms of reducing the rates of post-operative surgical wound dehiscence. Neither did it affect the time to wound healing or analgesia utilization afterwards, or time to return to normal activities. Given the significant additional cost of negative pressure dressings, and this also doesn't include the additional time taken in theatre to apply the dressing, we don't recommend its use as a routine prophylactic measure to reduce or prevent wound dehiscence. However, we do recognise that our study is limited by the fact that it's within a single institution, and we were using a single negative pressure device, though there are others available on the market. Thank you very much.
That's a beautiful paper. Because way back in 2000, my job was to do cardiac procedure, and I had 50% complication like what you have shown, and moved on to just only do a laser ablation, followed the minimal surgery. Now that you have shown that complications are the same, whether whatever dressing you do you change the way you approach pulmonary sinus in 2023?
I think our routine at our institution, we have been using snap dressings before this study, and we were obviously using it during the study, whereas now the trends after these findings is to not use it. At our institution, the practice is still to perform a cardiac procedure, though we recognise that there are emerging therapies such as endoscopic treatment. The tricky thing with endoscopic treatments is there wasn't very much literature on it at the time, and I guess the whole theory behind the cardiacis is to flatten the nasal cleft in order to try and prevent recurrence and take the wound away from the midline, whereas endoscopic treatment would get rid of the diseased tissue, but there is always that risk of it recurring again. So I think it's a matter of weighing up, what the patient prefers and where their values lie, and then trying to tailor the treatment to them. But I'd say at the moment the preferred treatment is still the cardiacis procedure.
Anybody wants to make a comment on this? Yeah.
Is Phil here?
I can make a comment. I think for the pulmonary diseases, you could have a really bad disease, and then there are kind of not too bad. And so for the really bad ones, I think the cardiacis method could be appropriate because you have to excise all the really bad tissue. But when you have a small one using trepanation, and that works pretty well. So you don't need to excise a lot of tissue for just a small disease. Yeah.
Thank you. And we found that in our study, as you mentioned, the disease burden did vary between patients, and we did measure the length and the width of those excisions and compare them between the groups to make sure there were no differences. And as you mentioned, the surgeons involved made sure to excise the amount of tissue involved, which did vary between patients according to their disease severity.
Minimally basic type approaches, and really the only way to avoid these high rates of complications is not to create a big wound in the first place. And the overall majority of patients don't have extensive disease that requires this kind of procedure, and with that, it's really had tremendous success. And we had sending all these patients who have had these big procedures and still fail, and then we have a problem.
Good morning, everyone. I'm very glad to be here to share my research. My name is Liang Yunyuan. I'm from China. The topic I'm going to report is exploring the value of rectal anal canal pressure management in the diagnosis of Hirschsprung's disease. I will report from 4 aspects. The first part is background. Hirschsprung's disease, that is HD, is a more common developmental malformation of the gastrointestinal tract, and its clinical manifestations are not typical. So the workload of HD screening is heavy. Currently, rectal suction biopsy, that is RSB, is the gold standard for diagnosing HD. However, due to the uncertainty of the test results, 17% of children still require repeated biopsy. Besides, RSV is invasive and has the risk of complications, which is not suitable as a preliminary screening method. An rupture manometry, that is ARM, is a high-definition, reliable, non-invasive test with almost no risk. But some scholars still believe that ARM has high false negatives and false positives, especially in neonates, so we conducted the following study. This study collected the rupture and canal pressure records of children with high suspicion of HD who were diagnosed by RSV at our hospital from November 2019 to September 2021. The RSV results were used as a diagnostic gold standard to explore the sensitivity, specificity, accuracy, positive and negative likelihood ratios, and the positive and negative predictive values of the arm in the diagnosis of HD. The inclusion and exclusion criteria are as above. This study included a total of 170 children. Among them, the sensitivity of arm in the HD diagnosis was 98%. The specificity was 65%, and the accuracy was 93%. The HD diagnosis was 98%. The positive likelihood ratio was 2.83, and the negative was 0.03. The positive results of arm is more important to HD. The positive predictive value was 94%, and the negative was 85%. Detailed results can be seen in the table. Through age stratification, it was found that the sensitivity of arm for HD diagnosis in each age group was relatively close, but the neonatal specificity was only 33%, which was significantly lower than that of children in other age groups. The specific results are shown in the following table. So, we concluded, ARM is a valuable screening tool for HD. It has high sensitivity in children with HD at all ages. However, in the neonatal, ARM diagnoses HD with high false positives, and the clinicians need to combine the clinical symptoms of the children with RSV results to confirm the diagnosis. Of course, it is also necessary to develop a more reasonable diagnostic gold standard for newborns to further explore the diagnostic value of arm in the newborns. That's my report. Thank you.
Thank you very much. Are there any questions? I was going to ask a question, if that's all right.
Good morning, everyone. Analysis of possibility, communication, and long-term.
Sorry, we just need you to talk a bit closer to the microphone. Is that possible?
Sorry.
Thank you.
The analysis of observative complexity and term efforts of total clinical injuries in children. They summarize the clinical features of postoperative complication of total clinical injuries in children, and to explore the efforts in postoperative complication and long-term efforts. Postoperative analysis of data from 24 children with TCA after Oxford Medical University with from the journey 23 to journey 13 23, the detailing information is as follows. Gender information, gender, 21 boys and 3 girls, age 2 to 2.5 day, digit 2.5 for 241, current manufacturers, Merkel developed 2, Tresmere 21 surgery, and real failure 3, nuclear theory 2, Cyprus chosen 2. Non-clinical infections, novel intestinal selections 18, flourishing of the digestive tract 8, prototeris and toxin shock 2, infection of ails 9. Rocky and examination, adenoids, examination and infections, non-intestinal structure. Daniel Emmanuel, engineers, no cover consistent. Operating, translating isochroma to staging torn, coronary, medical surgery, lapscos, essential total and comical. Connector as medicine, so I'm 38. Last course, as agent notified, becomes 3. Course 2. Result 1. Camille Ernison. Computer, Samuel Sony, hacking, H86, asthmatical structure, 1. 2. Asthmatic muscle facials, shears, infections, 2. All crossed by improved annular declines. Surgeon after notified behind surgeon, 2. All of them, they are resolutions by the poor operation. Actually, so that analysis the operation and the blood and the declaration after operation can reduce the post-operative complications and the patients can put deferred infections and process. Thank you very much.
Thank you, Dr. Liu. Any questions from the floor for Dr. Liu?
Are you doing routine investigation to know the level of that egg and yam segment in investigations, like frozen sections during final surgical incision?
Good morning and thank you for the introduction. Okay. So assessment of post-operative bowel function is important, but unfortunately there is not much information in regards to consistency and usability of the systems. So our aim is to assess the value of 4 common functional bowel scoring systems in the RN by comparing them across 3 domains, which are consistency of literature reporting, correlation with expected bowel function, and ease of understanding for patients and carers. So this cross-sectional study was done in 5 major pediatric surgical centers in Malaysia. After obtaining ethical approval and inclusion and exclusion criteria was fulfilled, interview was conducted, assessing subjects across 4 questions, which are clearly the JSGA questions, Japanese Society of Anomalies, Schneider and Rickenback. So we assess them as well as ranking the questionnaires according to the ease of understanding. So data analysis is centered on assessing the three domains. We are employing multiple statistical analysis methods. So the results. The mean age is 10 years old, predominantly male. We have 39 correspondents which consented, and 23 of the patients consented as well as fulfilling the inclusion criteria. So that makes a total of 62 patients. In males, recto-urethral group predominates, while in female it is a vestibular group. Okay, this is how we mark the scoring systems based on the three domains. For the first domain, comparison of the protocol scores rated by patients and parents. We found out that the Kelly system showed moderate correlation between parents and patient scores with statistical significance. No other scoring systems achieve statistical significance. For the second domain, we found out that Kelly ranks the highest in assessment of ease of understanding. And then for association of each bowel function scoring system with type of anomaly, we found out that Crickleback scoring has moderate correlation and fair correlation for Kelly and others. All in all, we found out that Kelly actually performs best overall. So our limitations for this study is that we conducted it during COVID-19 pandemic, so the restrictions were there. And we did not take account of confounding factors such as associated anomalies. So we concluded that Kelly questionnaires performed best overall when considering three key areas of assessment, which are parent-patient interactive correlation, association between type of anomaly and bowel function, and ease of understanding. Thank you. Any questions?
Thank you. I wish Dr. Justin Kelly was here to listen to this. We will take the question from.
I want to make sure. So how did you get the information from the patient about the caring scores?
We asked the patient direct forms, or if they are not possible to meet face to face, we ask them to answer by either Google form or we mark the questions. So we try not to get parents to intervene because it will produce bias.
Can I ask my co-host, Sebastian, who's taken over from Justin Kelly, to make a comment on that?
I think I've taken it from John Hudson, who took over from Justin Kelly. Yeah, it's great to see the Kelly score still being well validated. The question I had was, what are you doing now with this information? Are you using the whole Schneider and Crickleback, or are you just using the Kelly scores in your clinical practice?
Based on our data, we suggest we use Kelly. However, future studies can look into this and further validate our position, our data, or contradict it. Yeah.
Thank you.
Okay, thanks.
Very good morning, greeting from India. I am going to talk about the management of congenital pouch colon, our experience. This is one of the slides not moving. Yeah. This congenital pouch colon is also known as congenital short colon, and this is associated with erectile malformation. And incidence of pouch with erectile malformation is basically seen in the Indian subcontinent. In India, it is 5 to 10% with erectile malformation, but it is less in other part of the country. The congenital pouch colon are basically 4 types. It is based on the normal colon present proximal to the pouch, and it is usually associated with urogenital fistula. Our aim of this study is to present and share our experience in the management of congenital pouch colon. Next.
No. Back. Yeah. So we have treated 64 patients over a period of 5 years. It's basically a retrospective study. And the diagnosis was based on the clinical examination of the patient along with the plain X-ray of abdomen as well as contrastable rectal field. As you can see, a large gas shadow which is occupying more than 50% transverse diameter of the abdomen. His diagnosis was made, and then medical record of these patients were reviewed. You can see the associated anomalies with anorectal malformation with pouch colon, and you can see mostly the urogenital problems are most common, followed by the cardiac anomalies. These are the type of pouch colon distribution. Most was type 1, that is the 33 cases, followed by type 4, and then 11, and then type 3 was less common. So after resuscitation, the primary diverting colostomy was done, that is the window in 38 patients, ileostomy in 10 patients, and colostomy in 11 patients, and 5 patients were operated, some were else, and then deferred after initial colostomy. Next please. Sorry. Previous slide please. Yeah. So that I have presented. Next please. Next, yeah. This is a anorectal malformation with pouch colon. The window colostomy was done, and after 3 months you can see the cologram which is showing the dilated pouch with colovesical fistula. Next please. So in the second stage, the fistula was ligated, and then tapering coloplasty was done along the mesenteric border. Next please. See, then tubularization of the pouch was done around 7 inches long, and then abdominoperineal PSRP was done, and followed by the distal cologram that's showing almost normal looking colon. We have completed all stages of surgery in 50 patients, coloplasty in 34 patients, excision of pouch with colonic pull-through in 16 patients, and there were 12.5% mortality due to severe sepsis and associated cardiac anomalies. And follow-up range from 6 months to 5 years, no colonic dilatation. Our patient had a fair bowel control with good development. Next please. This is summary of our case. You can nicely see out of 64 patients, 42 patients came in follow-up. And to look the functional scoring in terms of the bowel voluntary bowel movement, so perineal swelling, it was ranging from 50 to 60% in type 1 and type 2 pouch, and 80 to 100% type 3 and type 4 pouch. Next please. So on conclusion, the management of pouch colon requires expertise and experience. Excision of the pouch is not required in type 1 and type 2 pouch colon. Properly created coloplasty gives better result and less complication. Next please. Thank you very much for patience here.
Thank you, Dr. Ra. Questions?
Thank you. My name is Shimoshima from Tokyo, Japan. I have 2 questions. One is, you did an application. Do you see any program about the motility? And the second question is, if I remember correctly, this phenomenon can associated with heart-spring disease. Have you seen ever such patient before?
Yeah, we are doing the tapering coloplasty, means we are excising the most dilated part of the bowel, which is on antemesenteric border, and making the lumen almost parallel with the lumen of the proximal bowel, which is type 1 or type 2 or type 3 pouch, and then making the abdominoperineal pull-through. This is the answer of your first query. Second is that pouch colon has not been seen in my center associated with Hirschsprung disease. Although there is a graph dilatation because of the impaction of the fecal matter in the egg and yolk segment, that lead to the huge dilatation. But moment you release the obstruction, they will collapse. So you cannot compare with the pouch colon.
Dr. Shaw?
Thank you for sharing that experience.
The urinary spread is how you're managing the skin from a urinary perspective. Do you get leakage of urine from your window colostomy, so you're taking it into the pouch there?
So most of these patients have a colobasal fistula. So we are disconnecting this and making a tapering of the colon and closing that fistula. They are usually present at the thigh bone and they might associate it with other associated urogenital problems that we handle later on.
What about your first operation? Excuse me, your first operation where you formed the window colostomy and you haven't separated the urogenital tract?
Sir, if you are diverting the colostomy or window colostomy, moment you will divert it, the pressure will release and there is a functional closure of the fistula. So there is no need of going to do a heroic surgery there. And the second stage, when you are planning for tapering coloplasty, you can divide the fistula and bring the tapering coloplasty and bring down the perineal PSR.
Thank you very much for your experience.
Thank you, sir.
Okay, thank you for your person. Today, I'd like to talk about comparison of postoperative urinary complications in lab and pre-op. Postoperative long-term urinary complications are affected by sacral anomalies and surgical approach. In this study, we compare lab and pre-op in terms of postoperative urinary complications. Between 2001 and 2022, 45 patients undergo surgery for ARM. 29 patients with high-type ARM underwent lab, and 60 patients with intermediate type ARM underwent pre-op. Before surgery, we performed BCUG and sonography to check the diameter of fistula and distance of inflow angle between rectum and the vessel. In lab, we dissect the fistula until its diameter less than 5 mm. In PSAP, we inside and open the posterior rectal wall and radiate the fistula interluminally according to the original Penrose technique. After surgery, we perform BCUG at 2 weeks after surgery again and to check the presence of remnant fistula and residual urine. Postoperative urinary complications were identified in 12 patients. All cases with remnant residual fistula and neurogenic bladder dysfunction were identified in lab group, and all cases with residual injury were identified in PSAP group. Remnant residual fistula were identified in 4 patients. All cases were asymptomatic and follow-up without treatment. The instance of remnant fistula improved between the earlier decade and the later decade. Neurogenic bladder dysfunction were identified in 5 patients. All cases had spinal anomalies, and 2 cases were free from shear at 7 and 30 years after surgery. Residual injury were identified 3 patients. All patients were performed intraoperative suture repair, and there was no cases showing postoperative leakage or stenosis. The instance of remnant fistula decreased with maturation of technique in later periods. In our institute, it is important to check diameter and the inflow angle of fistula by preoperative sonography. And 1 case of remnant fistula which developed into mucinous adenocarcinoma was reported. So long-term follow-up is required for untreated remnant fistula. In neurogenic bladder dysfunction, 2 patients were free from shear at 7 and 30 years after surgery. So preoperative evaluation of sacral anomalies and postoperative urinary drainage are important. Risk factor for residual injury were acute angle of fistula insertion, which create a long common wall between the vessel and rectum. So existing lateral dissection of the rectal wall may injure the posterior wall of the vessel. All 3 patients with residual injury underwent intraoperative suture repair successfully, so it's important to detect residual injury during surgery and undergo intraoperative suture repair. That concludes my presentation. Thank you for attention.
Thank you for a great paper, because we never discussed about complications. You are brave to come and talk to us about complications. There are two questions.
Anorectal prolapse is a common complications after anorectal plastic anorectal malformation. According to the literature, it occurs about 5% after PSA, 14% after LAP. Nowadays, the etiology remains unclear. Currently, the surgical technique for correction is not consensus. The recurrent rate varies greatly between the study from 2% to 33%. The aim of our study is to investigate the anatomic disorders and evaluate the surgical techniques in managing this challenging problem. The study was carried out on 83 patients with evidence for thickness rectal prolapse. 60% of the patients are associated with high type of anorectal malformation. About 59% was treated originally by LAP. The following anatomical disorders were found in our study: excessive rectal wall, patulous anus with dilated muscular tongue, hyperplasia rectal fat, anorectal prolapse with discontinuity of longitudinal muscle fibers, anal dislocation from the center of the sphincter muscle complex, and a pure rectal prolapse with no signs in the location of the anus. Excessive mobile rectum with interception. So our study found that all the patients suffer from the excessive rectal wall. 79% of the patients with patulous anus with dilated muscular tongue and was treated by narrowing procedure. 67% with hyperplasia rectal fat and were treated by fat tissue resection. 22% of patients with hypertrophy and a dilated terminal rectum, and the rectal resection was needed. 17% of the patients with anorectal prolapse with the discontinuity of the longitudinal muscle, and the reconstruction was needed. 14% of the patients with pure rectal prolapse, rectal trimming was performed, and 7% of the patients with mislocated anus from the center of the sphincter muscle complex, rerouting procedure was performed. 3 patients suffered from the mobile rectum with interception, and the rectopexy was undertaken. Wound infection occurred in 6 patients, 5 spontaneously cured, 1 developed anal stenosis. Recurrence occurred in 2 patients, 1 after treatment, the other one after rectopexy. Our cosmetic result, looked satisfactory. All the patients remained voluntary bone wound after repair. By our stratified technique, the no or grade 1 soiling achieved a high rate of grade 1 soiling from 65% to 88%. However, 3 of 12 patients with grade 2 constipation upgraded after repair to grade 3 constipation. Now, ladies and gentlemen, our study demonstrated ARM-related anorectal prolapse closely associated with excessive rectal wall, loose muscular tunnel, rectal fat hyperplasia, terminal rectal dilation, discontinuity of longitudinal muscle, anomalocation, and excessive mobile rectum. The stratified technique was effective for correction of these difficult situations. Thank you for your attention.
Thank you, Dr. Lee, for your large experience. Do you have a question?
For a nice paper. I want to ask, are you doing MRI for every patient of rectal prolapse? How are you evaluating these patients? Are you doing MRI for all the patients?
Moderate, evident prolapse.
Before you operate on them?
Yes, before surgery, we evaluate the patient by animal and also by MRI to evaluate the pelvic floor and the rectum. Yes. Routine. Yeah.
Dr. Pena recommends during the beachside procedure putting sutures through the rectum to the side walls so that the prolapse doesn't occur. Despite doing that kind of maneuver, you still get this kind of result.
Yeah. Actually, in this group of patients, also include the patient after penile procedures. Yes. Even after posterior sagittal approach, the rectal prolapse cannot be avoided.
One final question?
Thanks for your presentation. I have one question about the palliative.
It's one reason because in China, the lab procedure become popular, so the patient number of the patients is more come from our center. Even because after in lab procedure, the rectum was not sutured with the surrounding tissue, so it's more likely sliding through the tongue and then the rectal prolapse developed. I think this is the reason why after lab the incidence for prolapse is higher than PSAP. Thank you for the question.
Thank you. Thank you very much. It's the end of the session. I want to thank Raj.
Session is session 11, clearly 2. And actually one paper from thoracic section is moved into this session. It's going to be the last one. So supposed to be the 9th presentation in this session. So the first presenter is Dr. In-Go Ho. The title is The Optimal Timing of Surgery for Prenatally Diagnosed Choroidal Cyst. Please.
Choroidal cyst. The choroidal cysts are increasingly being diagnosed unclinically. In patients with choroidal cyst is experiencing symptoms after birth, depending on the patient's clinical condition, early surgery intervention is essential. However, the optimal time of surgery intervention for those asymptomatic choroidal cysts remain open to debate. So this study aimed to identify the optimal surgical time by comparing the surgical outcome of asymptomatic choroidal cysts according to surgery treatment time. We are retrospectively analyzing medical record of patients who underwent surgical treatment for choroidal cysts with an antecedent diagnosis at our institution. Starting period from 50 years, we investigated each patient demography, type of choroidal cyst, serial liver enzyme, and surgical outcome according to surgical time. In this study period, total 93 infants were performed instead of choroidal cyst. Among them, 16 patients had antecedent diagnosis of choroidal cyst. Of these, 21 developed symptoms directly after birth, while 38 patients remain asymptomatic, and 9 developed symptoms pre-operatively. To compare surgical outcome, asymptomatic patients were divided into 2 groups, early and late, based on the age bench of 30 days. The patient median gestation age was 38 weeks, and the median birth weight was 3.6 kilograms. The median neonatal diagnosis gestation age was 22 weeks. The CT size was significantly larger in group with symptoms directly after birth. The presence of epipedia rate was 72%. There was no significant difference between each group. The intraoperative cholangiography was performed in 50 patients and 58% patients had obstructive cholangiography. A significant obstructive cholangiography was observed in the group which progressed to symptom and the group with symptom directly after birth. The total life classification was no significant difference between each group. The median follow-up was 4.3 years. This table is clinical information for asymptomatic patients. The patients were divided into early and late surgical group, and 13 patients were classified by early surgical group with ESG, and 25 patients were classified as late surgical group LSG. The prenatal diagnosis time, median gestation time, presence of epipedio, mean seat diameter, and seat of type of seat was no significant difference. All ESG patients underwent surgery with open method, while in the LSG group, 30 patients underwent surgical with the open method and 12 patients under robotic surgery. The operation time was longer in ESG than LSG group. Furthermore, compared with LSG, the ESG had longer time to resume full diet, during duration, and post-operative hospital stay. There was no significant difference in post-operative complication, but complication occurred in 2 patients in ESG. 1 patient had bile leakage and 1 patient had portal vein cavernous from transformation. We also identified the indicator of progression to symptoms through biochemical investigation and anatomic features. Patients who progressed to symptoms had a higher level of AST, ALT, gamma-GT, total bilirubin, and bilirubin compared to patients in the asymptomatic group. In anatomical features such as mean seat diameter, presence of epipedio, and total type was not significant different. However, the operative cholangiography was more obstructive in patients who progressed to symptoms. The serum liver enzyme significantly improved in both groups after operation. The AST, ALT, total bilirubin, bilirubin, and the gamma-GT were at normal level at the 6 months follow-up. There was no difference in recovery of liver function according to the operation time. Based on our data, we proposed the algorithm to determine the appropriate surgical time for patients with asymptomatic colorectal cyst. All patients underwent ultrasonography and the MRCP after birth to confirm the diagnosis of colorectal cyst and the total time. Biochemical laboratory tests were performed to confirm obstructive cholangitis, obstructive cholangiocarcinoma. Regarding follow-up, the laboratory tests were performed in first and second week to check obstructive jaundice, and in 4 weeks, laboratory test and ultrasonography were performed to check if the size increase or sludge performed. During the follow-up, if patients have clinical symptoms, obstructive jaundice, CT size increase or sludge were observed, early surgery intervention was performed. The surgical treatment was not performed in absence of affirmation observation, and patients were followed up until reach of age of 4 months or weight of 7 kilograms. Based on the study, asymptomatic patients should be close monitoring, and we recommend that defense surgery intervention be postponed until 4 months of age or until weight reach 7 kilograms. Thank you.
Excellent study. So, thank you for the presentation. Do you have any experience of pancreatitis before the operation? And do you have any experience of pancreatic leak after the operation? Thank you.
Oh, we are not experienced after operation in pancreatic leakage.
please.
Thank you for sharing this. So a couple of questions. In the prenatal diagnosis, all the series represented, what is the value of the MRCP? What does it add to the imaging you have from prenatally and post-op ultrasound? We don't do routine MRCPs on these babies. We already, especially if you're going to do a cholangiography at the time of surgery, usually it requires a general anesthetic to do an MRCP on the baby. The second question that just wasn't clear to me, do you consider a high bilirubin a symptom? Is that a symptom of the baby is otherwise well, thriving, no other symptoms, but just has a high bilirubin? Is that considered a symptom?
So the first question is in MRCP, we can different diagnosis if a patient have a biliary type biliary atresia or another like a subhepatic cyst or mass, we can different diagnose using MRCP. And excuse me, I can't understand the second question.
Is high bilirubin a symptom by itself?
Oh, maybe the obstructive cholangiopathy occur the high bilirubin.
So, I have a question. So, time to start the diet and also the length of stay is shorter in the late operation groups. It is not something related to the MIS operation is really involved to the group.
Yes, next question. We are agree your comment. The surgical results show the more short hospital stay and diet duration in late surgery. That's the reason why we can perform the robot surgery, because we closely monitoring the patient due to hip rubber, and we apply the robotic surgery. This study is another advantage for the late surgery.
Thank you.
Okay. Thank you for your introduction. Good morning, ladies and gentlemen. The topic of my report is conjugated bilirubin and the total bile acid of the first 2 weeks can be used to differentiate cystic biliary atresia from cortical cyst detected prenatally. As we know, increasing number of hepatic hair cysts were detected prenatally. Among them, the CBA and the CC are the most common, the most disease. The CBA and CC should be differentiated as soon as possible after birth, because the prognosis of CBA is strongly related to the operation age. And it has been reported that conjugated bilirubin could be used for screening biliary atresia in the first few days of life. So the purpose of our study is to evaluate the diagnostic performance of conjugated bilirubin and total bile acid in differentiating CBA from CC. And the second purpose was to elucidate the prenatal US features of CBA. The fetuses with hair cyst detected since the second trimesters were followed up until the definitive diagnosis of CBA or CC was made. In the meanwhile, 2 times of liver function biochemistry were tested. The first time within 1 week after birth, and the second time between 1 to 2 weeks after birth. And the values of conjugated bilirubin and TBA were retrospectively compared between the 2 groups, and their US features were also compared. we want to find some cutoff values and to evaluate the diagnostic effectiveness. From 2020 to 2021, 143 fetuses with hydrocyst detected prenatally we reported from 13 centers in China. Among them, 37 was CBA and 106 was CC. When we first compared the US findings between the two groups, the first parameter to be considered is the volume increase multiples. We found that in the CBA, the cystic increased by 1.48 times. And in the CC group, the cyst volume increased by 8.34 times. There are also some other US features which was specific for CPA, such as the most outstanding was the morphology of the gallbladder. We found that in CPA group, the dysmorphic morphology of the GB was the most often reported, such as tubular shaped GB and rigid GB with thick, smooth, and irregular inner wall. And when the volume increased multiples was used as the diameter to differentiate CPA from CC, we found that at the cutoff value of 3.9 times, the AOC was 0.820. The sensitivity was 83%. And the negative predictive value was 94%. The results showed that both CB and CBA was increased in the both CB and the TBA in CBA group was much higher than that of CC. We also enrolled 200 infants with the diagnosis of neonatal jaundice. We found with the increase of TB in the jaundiced units, the value of CBA, the value of CB and the TBA also increased, but the value was much lower than that of CBA group. And in the second week, both CB and the TBA increased in all three groups. But in the CC and the control group, the CB was not more than 17 millimole per liter, which was much higher, which was much lower than that of the CBA group. When we evaluated the diagnostic performance of CB and TBA in differentiating CBA from CT, because the prognosis for CBA is related with the early operation, so the sensitivity was the first parameter to be considered. Therefore, we found that the CB of the first week and the TBA of the second week demonstrate the sensitivity of 100%. So when we use the CBA in the first week to be used to differentiate CBA from CC, at the cutoff value of 22 millimole per liter, the AOC is 0.902. And for TBA of the second week, at the cutoff of 21 millimole per liter, the AOC was 0.860. So our conclusions are: the first, increased CB and TBA could be used for differentiate CBA from CC early after birth. And the second, the CBA cyst increased less than that of CC.
And the third is abnormal GB on prenatal US is a hint of CPA. Thank you.
Any question?
What is this control in the level of balance?
You start the CP or the TB?
Neonatal hepatitis.
Neonatal, the 99 percentile is 70 millimole per liter, as reported in the paper.
In your ultrasound, you base this data based on ultrasound diagnosis of biliary atresia. Have you confirmed that histologically or intraoperatively that indeed this correlates with histologic findings?
It was confirmed by the operation and all by the clinical outcomes. Thank you.
Okay, next one, Dr. Xu Wangjin. Dr. Xu.
Thank you for introduction. This is a prospective study. The cortical cyst is treated by cystic excision and hepatic cholangioscopy. And the leakage stenosis at the hepatic anastomosis site, malignancy in the long term of anastomosis for the hepatitis or intrahepatic products are known post-operative complications. Common hepatic duct, just as this is a hepatic anastomosis in cortical cyst, has not previously been assessed specifically for mucosal damage, inflammation, fibrosis, or premalignant histopathology, such as dysplasia, carcinoma, in situ, and malignant transformation. To evaluate histopathology, we evaluated histopathology of common hepatic duct just distant to the hepatic site at the time of cystic excision in pediatric and adult cortical cyst cases, prospectively, as I mentioned before. Subject, 65 cases, children 40, adults 25. As you can see, mean age, median 4 years old in children, 35 years in adults. And on the left slide, you can see cross-section of common hepatic duct from just distant to the hepatic anastomosis was obtained for histopathology. HID staining for checking the mucosal damage and inflammation. Immunohistochemistry was performed to see cell proliferation, chronic inflammation, dysplasia, and carcinoma. Muscle staining was used for checking the fibrosis. On the left, you can see the cross-section of the histopathology of the common hepatic duct. Green dotted line shows the internal circumferences of the common hepatic duct specimen. Red dotted line shows the damaged mucosa. So damaged mucosa rate is B divided A. So on the right side, you can see correlation between age and damaged mucosa rate. Very interestingly, in younger children, in younger patients, there is significantly more damaged mucosa. So this slide shows high serum amylase level patients. You can see the red dot. So high amylase level patients has more damaged mucosa and in younger children. So significantly more symptomatic cases in children. So inflammatory score in younger patients, significantly more inflammation. And cell proliferation, again, in younger patients, significantly more mucosal regeneration. So fibrosis score, there is no difference between children and adults, no correlation between fibrosis and age at cystic excision. So the dysplasia was identified in one case, 4-month-old cow with cystic cortical cyst, as you see here. So in conclusion, presenting symptoms being more severe in younger children may explain the significant inverse correlation between age at cystic excision and damage mucosal rate and inflammatory score identified in the study. Significant inverse correlation between Ki-67 and age at cystic excision could reflect more active hepatocyte-related mucosal regeneration seen in children compared with adults. So dysplasia identified in the common hepatitis, just registered hepatitis sites in 4-month-old patients, suggest that surrounding tissue should also be thoroughly examined using specimens taken during cystic excision, and the follow-up should be more intensive as dysplasia implies malignancy. Thank you for your attention.
Thank you. Is there any question?
Very interesting, Anna.
I
noticed that there are patients. I wonder if it's because it's correlated, like you said, to the symptoms. There are these asymptomatic patients that you operate on because you detect prenatally. Did it correlate with that? The more severe ones that you found the scoring with the
The
symptomatic
prenatal
ones?
one. In prenatal cases, between the prenatal cases and inflammation and other factors. But before operation, before this study, I was expecting the more severe inflammation in adults, but surprisingly more severe inflammation and mucosal damage in children. So I talked to the adult general surgeon. General surgeon thought children has more damage because they said the symptom is severe. Severe in children.
Do you have any comparison with the time, the manifestation and the symptoms between the children and the adult groups? Maybe the time of manifestation of the symptoms and symptomatic.
In the children, we didn't check, but in adults also we didn't check. But as you can imagine, in adults, most of the cases are less symptomatic, so longer time that they have a disease for a long time, but less inflammation.
Because asymptomatic, I said, because a long time, but asymptomatic. So the time that they are symptomatic may be valuable for these exchanges.
Yeah, I think as far as the patient is asymptomatic, I think mucosal damage and inflammation is less.
I have one question. The TMR is.
Thank you for introducing me. My topic is perinatal detective cyst, cortical cyst, or cystic urinary atresia. Subarachnoid cyst detected through ultrasound during perinatal period can be diagnosed as cortical cyst, cystic urinary atresia, elevated multiplication, or lymphatic malformation. When a subarachnoid cyst is identified during perinatal period, in most cases, initial suspicions often lean toward cortical cyst. So most patients receive information about cortical cyst. However, It is not uncommon to be diagnosed with cystic biliary atresia with more unfavorable prognosis. So we aim to investigate the distribution of the final diagnosis of perinatally detected subhepatic cyst and to compare the patients diagnosed with colorectal cyst and cystic biliary atresia. We conduct a retrospective review of patients who were detected subhepatic cysts through ultrasound during prenatal period and or within the first week after birth between January 2012 and December 2022. A total of 52 patients were included. The most prevalent diagnosis was a colorectal cyst, accounting for 71.2%, followed by cystic biliary atresia at 15.4%. There were 3 cases of alimentary tract duplication and 1 case each of non-cystic biliary atresia, gallbladder duplication, lymphatic malformation, and lumen finding. The following table is a comparison of patients diagnosed with colorectal cyst and cystic biliary atresia. Statistically significant differences were noted in direct bilirubin, gamma-GT, AST, and ALP level. This finding consistent with the well-known characteristics of colorectal cyst and cystic biliary atresia. The cyst size measured preoperatively showed no significant differences. And when comparing the gestational age at which the cyst was first discovered and the cyst size measured on the latest prenatal ultrasound, there was no significant differences between 2 groups. However, these analyses were limited by the small number of patients with available ultrasound images or records. One patient included in the study had a cyst detected during prenatal period, but its size gradually decreased and disappeared. After birth, further evaluation leads to a diagnosis of biliary atresia. This patient had a serial ultrasound imaging and with well-documented records. It allowed for early sufficient and timely surgery. Conclusively, subhepatic cysts detected during perinatal period were predominantly diagnosed as colorectal cysts. However, in this study, patients diagnosed with cystic biliary atresia was 15.4% with significant feature. Therefore, it is important to recognize the potential for cystic biliary atresia in case of perinatal detected subhepatic cyst. Also, by closely monitoring the cyst through serial ultrasound, it may be helped in final diagnosis. Thank you for attention.
Thank you for interesting studies. Any questions or comments? So if you find the biliary atresia earlier than usual, so when do you do the side operation? Like right after the diagnosis, or wait for 30 days or 40 days?
Sorry, I didn't understand your question. Woman?
So because of your ultrasound, the first week of the after birth, then you take the ultrasound first. Then if you find the patient has a biliary atresia, when do you do the Kasai operation?
We suspect the patient had a biliary atresia. As soon as possible, we conduct a Kasai operation.
Okay, thank you.
We move to the next presentation. Dr. Mohamed.
It's so nice to be here. Good afternoon, everyone. as we know, it's still difficult to diagnose biliary atresia. There are many modalities of diagnostic tools to distinguish BA from other causes. And ultrasound examinations will have great value as initial modality because one cost as the ultrasound was cost effective, no ionizing radiation, and do not require sedation. And this is HAD or hepatic artery diameter, new features in US examination. And HAD is significantly larger in infant with biliary atresia with cutoff over 0.15 centimeter. This is a new features in US exam and uncommon in our institution. The causes of HAD enlargement is because compensatory change to improve the blood supply for biliary trees, secondary change of liver cirrhosis, and essential vascular malformation. And we compare this HAD with the most favorite site in US exam to diagnose BA with there was TCS, triangular cord sign. A cross-sectional study was conducted with the inclusion criteria of children diagnosed with neonatal cholestasis who underwent liver US examination by a single operator, a pediatric radiologist consultant. And the diagnosis of BA was established using interpretive clinical findings and coloniography. In the non-BA group, the diagnosis was determined by clinical improvement during follow-up period. So the result, we have 50 neonatal cholestasis patients who had undergone a liver US examination were included in this study. 25 patients were diagnosed with biliary atresia and 35 other patients have diagnosed with non-biliary atresia. There was no significant distinction between the age and gender group. The group were homogeneous and had the same characteristic and could be compared. So 18 patients with BA had positive HAD and 14 BA patients had a positive TCS. Both of these features had a significant correlation with the incidence of biliary atresia. And detection of HAD resulted in a greater accuracy and then sensitivity, specificity, than TCS. So it concluded that enlargement of HAD had a better performance than TCS. As a diagnostic tools of BA, and HAD cannot replace TCS, but it can be helpful to distinguish BA from other causes of neonatal cholestasis if multiple US features are carefully evaluated. Thank you.
Thank you. Thank you very much for your presentation. I'm Fujishiro from the University of Tokyo, Japan. I'm interested about your BA patient is really high age, I guess median age is 5 months. So maybe BA with higher age have higher hepatic artery diameter. Have you checked the correlation between the age and diameter of the hepatic artery?
No, we not compare the age of whether the age is correlate from the diameter of the hepatic artery.
Thank you. Maybe you can check later.
Okay, thank you.
Maybe I missed it on your slide.
Good afternoon, everyone. Diagnosis of biliary atresia is challenging and invasive. As for now, there is still no effective bedside diagnostic scoring system for BA. The simple biliary atresia scoring system, SBASS, was actually introduced by a group from Singapore, presented at ASPS in 2019. However, it is not yet validated. The scoring system consists of 4 parameters, 2 parameters from the ultrasound, as well as another 2 parameters from the liver function test. Maximum score is 6. Hence, the aim of this study is to evaluate the diagnostic value of SBASS in differentiating biliary atresia from other causes of infantile cholestasis. We performed a prospective cohort study in all patients with a cholestatic jaundice that was referred to throughout biliary atresia. The study was done for 18 months duration in 3 pediatric surgical centers in Malaysia. Data collected consists of a thermographic, ultrasound finding, as well as liver function tests. All the patients were managed according to the standard institutional protocol and followed up until the diagnosis has known. Cholangiogram and liver biopsy were performed to confirm diagnosis either BA or non-BA. SBASS was then applied to all patients and the score were compared to the eventual diagnosis. Here is the result. Of 97 patients referred, 73 were included in the study and 72% were diagnosed with biliary atresia. To assess the applicability of this scoring system, the cutoff point was determined using the ROC curve, and the area under the curve is 0.901, which indicate a good discrimination of biliary atresia using this scoring system. We choose the cutoff point 3 and above because it gives a high sensitivity of 96.2%, while the specificity is 91.9%. 96% of the patient with A has a score 3 and above, while 62% of the non-BA group has a score less than 3. Limitations identified as lack of standardization of the ultrasound protocol in the 3 centers may affect the reports as well as interpretations result. Hence, a more standardization of the ultrasound is needed. Secondly, BA is a progressive illness. Biochemical and anatomical morphology can actually evolve along the course of the disease. At very lower gestational age may result in a falsely low scores and even in the presence of BA and vice versa. In a nutshell, this scoring system is validated. It is highly sensitive, non-invasive, as well as reliable scoring system. Using this scoring system will allow exclusion of BA using a low-risk method, as well as thereby reducing the likelihood of negative surgical exploration. With that, I thank you.
Thank you.
Hi, thank you for a very interesting study for challenging subject. So my question is about the timing of this scoring system. So what age or what day of life you were checking this score? Or there may be any criteria?
Thank you for your question. Actually, we are applying this scoring system whenever we receive the referral to our center.
Gotcha. So as we know that biliary atresia is not kind of developing the disease, meaning the patient is getting high level of development day by day. So I'm just wondering if the bias is there.
That is why this is one of the limitations of this study. Actually, if a very early patient's referral at a very low gestational age, it can give a low score. Hence, we haven't explored the use of this scoring system reapplied in this group of patients. So it will be good for a subject of our future research.
So, SBA is a system which looks like very simple, only some blood samples and ultrasound. So, what do you speculate that why this simple method is effective for diagnosing pediatric? Because there have been many reports that discussing about how to diagnose the pediatric.
Okay, by using this scoring system, actually we can be more selective in the patients that we want to subject for intraoperative cholangiogram. For example, if patient has a very low score, less than 3, we could think of subjecting the patient to more less invasive methods such as HIDA scan or percutaneous drainage, so preventing from reduce the risk of GA as well as can reduce the operation resources.
Any questions? Thank you for the presentation.
So it's going to be the last presentation in this session. Dr. Koichi Deguchi, which is transferred from the thoracic section. Clinical pathological analysis of congenital cystic lung diseases, classification of subtypes and distribution based on bronchial obstruction sequence.
Thank you, Chairperson. And thank you for moderators. And good afternoon, everyone. So the advances in genetics are changing our understanding of congenital cystic lung lesions, such as KRAS mutation and type 1 CPAPs. So this study hypothesized that bronchial obstruction sequence, or bronchial aplasia, BA, is an individual disease entity distinguishable by histologic features. The purpose of the study is to reclassify the concept of CCLDs based on the concept of bronchial obstruction sequence. Patients who underwent surgical resection for CCLDs from 2010 to 2022 were enrolled, and 2 specialized pathologists reviewed histologic features in a blinded manner. And also bronchial aplasia was diagnosed according to the Langston's concept. So 4 key histological features of bronchial obstruction were recorded in the study, which is atretic bronchus, mucociliary, microcystic maldevelopment, and surrounding emphysematous change. All indicated obstructed peripheral airway during development. Here's a table showing histologic features of each CCLD subtypes. Of the 47 surgical resected CCLDs, the final diagnosis included 5 type 1 CPAMs, 19 type 2 CPAMs, and 11 intralobar BPS, and also 6 extralobar BPS. As you can see, type 1 CPAM have distinctly different histologic manifestation from the other 3 disease entities. Furthermore, histologic features of bronchial obstruction sequence were shared between type 2 CPAM and BPS sequestrations. So because all type 2 CPAM had features of bronchial obstruction sequence feature, so we diagnosed them as bronchial aplasia as a final diagnosis. Next, parenchymal maldevelopment features was histologically distinguished into 2 different types, which is cyst dominant type on the left-hand side and emphysema dominant type on the right-hand side. Also, proportions of each subtypes in bronchial aplasia and intralobar BPS are recorded as shown on the bottom. To summarize, our findings indicated that bronchial obstruction sequence is a common pathological mechanism in some CCLD subtypes. So our hypothesis below on the right-hand side proposes CCLDs are divided into 2 subcategories, which is bronchial obstruction sequence on the top, and also precancerous or malignant lesions. Thank you for your attention.
Good presentation, thank you. Please.
Thank you. I'll just take some issue with the definition. They will be a threat because they do not communicate with the bronchial tree. So it's important to differentiate those because it's not a pathological process. These were, they're remnants of the budding process that never communicated with the bronchial tree in the first place. So even though they will be atretic, they do not, I believe, carry the same risks. They do not get infected. They don't have the risk of malignant degeneration and all the other things that we think bronchial atresia implies. So I think it is important to differentiate the extralobar ones, not to group them with all the other malformations.
Thank you for the illustration. See the histological characteristics, and move on to check the interlobar and the bronchial aplasia, which we call BA. And that is kind of similar manifestation we could find. So that's first impression, and move on to the more detailed histological investigation. So your point is very good and very important too, in terms of dissection of the region or not, is very important for the patients. So thank you for the question.
Hi, this is Kuroda, originally from Tokyo, and I enjoyed your paper and I really am BBC. And my question is, did you see some KRAS mutation among the patients who had the type 1 CPAMs?
Yeah, so in
the type 2 CPAMs.
Thank you for the question. We haven't yet checked the KRAS, but of course our co-author, Mio Tanaka, Dr. Mio Tanaka, is checking the KRAS mutation in all the type 1 sequence, so we move on to that investigation. And furthermore, we have more new modalities of genetic sequencing, so we would like to check the difference between the type 1 and the other two entities. That will be very interesting. And in the future, we can find some biomarkers preoperatively to see which is precancerous or not. That is very important, I think, so we would like to try that.
Thank you. I suppose that the CPAMs should be redivided into 3 groups, with the group with the KRAS mutation and the group with the bronchial obstruction sequence, and maybe type 3 CPAM is a different disease, which is most critical. So I really enjoyed and totally agree with you. Thank you.
So, Christian? Now we are closing this session. Thank you for your attention. Thank you very much.
Jim was a global surgeon, and he was a global surgeon before global surgery was cool. He made it a huge part of his influence and his career early on, intermittently. And I can tell you that decades after Jim's presence, people still remember him and remember what he had done there. So this really was a big part of his legacy. Jim was also a mentor, and he took an interest in people. And I, experienced that myself early on. I first met him at a retirement party for Dr. Gibbs Andrews, who was our chief of pediatric surgery at Loma Linda. And I happened to mention that I was about to go on my first mission to Kenya. And Jim immediately took an interest, introduced me to people, and after I came back, called and wanted to know how things went. And we had never met before, but this was the kind of person he was. He really took an interest in human beings for who they were, and was always looking for a chance to provide mentorship to people. And Jim was not somebody with a prolific bibliography. He did not publish hundreds of manuscripts or have a huge research program, but he was full of clinical wisdom. And he often relayed that clinical wisdom to his colleagues. This is a paper from Dr. Alberto Pena, which was one of the first papers to describe the non-operative management of fistula, anal, and perianal abscess in babies. And before then, surgery was quite common for this condition. And Alberto notes in his introduction that it was actually Jim Worden who introduced him to the concept of non-operative management of these lesions and the fact that most of them will resolve spontaneously. So that was the kind of surgeon Jim was. He had built a tremendous amount of clinical expertise, and he shared it very liberally with his colleagues, not necessarily publishing it himself, but he was a very selfless surgeon in terms of sharing his experience. And then Jim also left a tremendous family legacy. One of his children was actually adopted. She was one of his patients with severe short bowel syndrome, passed away recently. And that also speaks to the kind of heart he was. But these are pictures that Jane Worden in the middle here just sent me the night before I left Montreal. And they have a family of 5 children, 18 grandchildren, and 10 great-grandchildren, all of whom are profoundly successful. So a tremendous family legacy as well. Now, Jim's legacy also continues at the University of California, Irvine, where he spent the last part of his career, a couple of decades before he passed away. And I was really privileged to follow in his footsteps. I didn't know then that I would be sitting in the office where he had sat for a long time. And this is really what made me want to memorialize his legacy. And in 2003, we created the Jim Worden Visiting Professorship Program. And I'm just going to take a minute to read you the very short description of Jim that stands in a plaque at the University of California, Irvine. It reads, M. James Worden was born in Ingersoll, Ontario, Canada on November 29, 1923. He earned his medical degree from the University of Western Ontario in 1950. He then completed his general and pediatric surgical training in Detroit from 1951 to 1955. He started his pediatric surgical practice at St. Joseph's Hospital in London, Ontario in 1956. A few years afterwards, he moved to Southern California to join Kaiser, where he built an extensive pediatric surgical career, and I believe that is the time he also joined Paps. Outside of medicine, Dr. Worden's passions were his family, hockey, sailing, and fishing. He departed peacefully on August 11, 1999, while fishing in Alaska. He is survived by his wife Jane, children, grandchildren. He is remembered at UCI and throughout the pediatric surgical community as a warm and caring surgeon, teacher, and friend. This event is a tribute to Dr. Worden's legacy to the university community and his 4 decades of compassionate care of children with surgical diseases. And this program is on its 20th anniversary. It has become a landmark of academic activities in Southern California, often attended by surgeons from around the area. The first visiting professor was my mentor, Jean-Martin Laberge. I was very privileged to go back as the 10th visiting professor after I left California. And the most recent one, the 20th annual one, was Mark Davenport. And the program still continues to attract really the very best in pediatric surgery, the who's who in pediatric surgery. So that has been also a huge memory to Jim. And there's also been updates in the Paps issue of the Journal of Pediatric Surgery quite frequently. You can see here the list up to 2014 of the surgeons who were invited to be GAP Fellows. Many of them now have become permanent members of Paps and are very active in the organization. And if we take it till today, we've had 43 GAP Fellows, and these are the provisions that GAP, that Paps provides for them. And it's really been a tremendously successful program. But GAP is not just about inviting a surgeon to come and attend our meeting. It's really about relationships. And this is an article that Dunya with Maryland's Health published in the recent Paps issue. As you know, Dunya was a pediatric surgeon in Afghanistan. She's the second from the left there. On the very far left is her sister. And you know, Paps and GAP really saved Dunya's life. You know, Marilyn was very instrumental in getting her out of Afghanistan, where she lived in absolute fear for her life for several weeks. And Dunya is now our fellow at the Montreal Children's Hospital, doing a research fellowship for 2 years. And this is a picture of her with many of our trainees just last June with Emmanuel Ama in the middle there as a visiting professor. So this is what GAP is really about. And it's also about reducing the gap, really, between North and South. I'm very proud that Emiliana, our last year's fellow, became the first LMIC surgeon to be featured in a Clips, a CB Clips episode. If you don't know what that is, just Google it and it will lead you to those clips. And actually, Emiliana also served as a faculty member in an international omphalusia webinar that we just had through the Hendren project. So this is the idea, is that the surgeons coming from LMICs are not just here to consume education, they're here to provide education. They have a lot to teach us. It's really all about partnership between all of us around the world. And then I have to mention, of course, Cynthia Reyes, who chaired this program for 10 years. Cynthia also couldn't come this year. This is a picture with her, Alberto Pena, and Jim Gordon when Alberto came to UCI for the first time. And of course, the spirit of Paps for the last the spirit of GAP for the last several years, Marilyn Butler, who again could not be with us this week. There are also some little gaps, I would say, not just the visiting professorship program, the visiting program, but Arturo Aranda, who's going to be the next co-chair of the GAP, invited residents from Ecuador who were with us last year, 2 very bright residents that I actually got to interact with quite a bit, who are coming to the US for observership. So these are other global surgery activities that GAP can inspire. This is our GAP committee for this year, and this is the GAP committee that will take over with Grace and Arturo now the co-chairs. And there is no specific number of GAP members, so if you're interested, you could speak to them, and we would love to have you join this group. We've also suggested a more objective way of choosing GAP fellows in the future, so there will be a bit more of a scoring mechanism, and both the sponsor and the applicant will have to write a little bit more about why they think they can benefit from this program. And finally, and I think this is really, really special, I call it gapping it back, like giving it back, because our previous GAP fellows are actually the hosts of this year's GAP fellow observership. And so I really want to thank Dr. Milano, who's been tremendously helpful throughout the last couple of months in helping us host and set up the observership, and Emiliana for being the host actually at her institution of our 2 GAP fellows. And Gennady, just at the reception a couple of days ago, said, you know what, I will fly them, I will give them train tickets to my city and show them around for the weekend. So I just want to thank all of them, and I have some maple syrup treats, which we call the food of the gods in Canada, for you guys afterwards if we're ready to take a picture. So with that, I'd like to introduce this year's GAP visitors, Dr. Surima Lucatitara from Thailand and Dr. Jorge Rodriguez from Mexico. Surima did medical school at the Faculty of Medicine in Ramata Bodhi Hospital of Mahidol University, and then did her residency in King Chalagwara Memorial Hospital and the university by the same name. And I know people have told her many times during this meeting, you're a pediatric surgeon, you're very, very young. But that speaks to her brightness, and she actually has been a pediatric surgeon for 5 years. And Dr. Jorge Rodriguez, who is currently practicing at the Instituto Mexicano del Seguro Social, did his medical studies at the University of Montemorelos, and then surgical residency in Guadalajara, and he also completed his pediatric surgery training recently. So we have 2 very young and bright pediatric surgeons with us today. And Surima will have you come and speak first, and then Jorge, and we will have a few minutes at the end for any questions or comments. Come on up.
Good afternoon, ladies and gentlemen. It's my pleasure to present as GAP Fellow today. I am pediatric surgeon working at Hat Yai Hospital, one of the government hospitals in southern of Thailand. Let's introduce the healthcare system in my country. Thailand has 66 million people in 2022, and 16% were children. The hospital cost is all covered by the government, but the laparoscopic instrument cost is not fully covered. Due to the low average family income, the extra cost of laparoscopic device is a huge burden. And the healthcare district were divided into 13 sections, and Hat Yai Hospital is the main government hospital in 12 districts. We look after 8 provinces. There were 1.3 million children in our district, and we have 18 NICU and 12 PICU. Our pediatric surgery team has 3 surgeons who performed an average 500 operations and 40 cases of neonate annually. And moreover, laparoscopic surgery has been increased by 70 cases in the past year. Minimally invasive surgery has been worldwide practiced in adult and pediatric patients for decades. We have many MIS training centers for adult surgeons. Hat Yai Hospital is the one has been one of MIS training centers since 2002. But however, we still need MIS training for pediatric surgeons in Thailand. As shown in this graph, in the past 5 years, our children got laparoscopic surgery only 1%, even in a common disease like appendicitis. We are facing a financial and training problem. However, we still try to perform laparoscopic surgery for our children. Begin with laparoscopic block training and cadaveric laparoscopic workshop. In Hat Yai Hospital, we began to perform laparoscopic surgery in children 5 years ago. Begin with the non-complicated surgery under supervision of our MIS adult surgeons using the reused adult instrument. After that, many expert surgeons from all around the world have come to visit Thailand and teach us, demonstrate many useful techniques. Then we perform more complex surgery on more minor children a couple years after we got a pediatric instrument. After the COVID-19 pandemic, I have an opportunity to learn more complex surgery, especially in infant and newborn. In the past year, our team started performing laparoscopy in infant, such as laparoscopic pull-through for Hirschsprung disease. Due to the limited instrument and human resource, it was challenging initially. We learned step by step, disease by disease. Now our team is familiar with laparoscopy in children. We can perform laparoscopy even during the night shifts. It can be done in 5 years ago. And statically, now we can perform laparoscopic surgery in children. In the common disease, more than half of total case now. The next step is to perform laparoscopy in newborn, and I hope our team will be ready soon. This is just the beginning of a long and exciting journey to advancing laparoscopic surgery in children in Thailand. I'm thankful to all my teachers and to Paps for their dedication to advancing surgery in children in developing countries. I'm excited about the future of this field in Thailand. And I believe that such an international collaboration is essential for the growth and development of this field. And I hope that in the future, we can send our staff to visit your facility to learn more complex surgery and technique. Thank you all for your time and attention. I'm looking forward to work with you. Thank you.
So I think Freeman has shown us that there are a lot of pioneers that we do not know about. Pioneers are not just people who start new procedures, but who really try to change their community. So on behalf of Paps, Serena, I'm going to present you with my labor of love. There's a lot of laparoscopic videos in this book I think you'll be able to benefit from. Jorge?
Hello everyone. I want to express my sincere thanks for having me award for the GAP scholarship. I'm participating for the 56th annual meeting. Okay, I want to show you a little where I come from and the school where I studied. Monterrey is the capital and most populous city of Mexican states of Nuevo León. It is found at foothill of Sierra Madre Oriental in the northeastern region of Mexico. The city has a population of over 5 million inhabitants, which make the second most populous metropolitan area in Mexico, only behind Mexico City. In Mexico, there are 4 health systems. Secretary of Health, which is free from entire population, Mexican Social Security Institute, which is for workers, and Institute of Security and Social Service of States, workers, which works individually by states. Private hospitals that can be for medical insurance expenses or expenses for patients themselves. The Northeast National Medical Center is part of the network of hospitals of the Mexican Social Security Institute, which is the largest public service in the country. This tier-level hospital receives patients with complex pathologies from Monterrey and other states of the Republic. It provides care to 4 states of the Mexican Republic: Coahuila, San Luis Potosí, Tamaulipas, and Nuevo León, with a total population of right holders almost 10 million. It has 42 medical and surgical specialties, of which 10 are pediatrics, including pediatric surgery. It was inaugurated in 1980. Since then, it provides its service. The pediatric surgery service has a total of 6 pediatric surgeons, 3 during the morning shift, 1 in the evening shift, 1 on night shift, and 1 on weekends. There is not enough staff to operate by clinics, so the distribution of service personnel is made according to the needs we have to cover the different areas. 5 of the 6 surgeons are general pediatric surgeons, and 1 we have a pediatric oncologist who is in charge of all these cases. Approximately 140 consultations are given monthly and a total of 35 patients monthly. The service has 8 beds, however, we always double the number of hospitalized patients. Additionally, 4 beds are shared in pediatric intensive care for all pediatric service. This sometimes handles the scheduled surgeries that we know will require this type of post-surgical care. Our largest patient population is oncology. So we have a great communication with our fellow oncologists and hematologists. This is how we capture the patients from the diagnosis of the disease and schedule them according to the chemotherapy sessions. Sometimes we are delayed with these patients since the drug for the proper chemotherapy treatment are not available, and this is sometimes fatal or causes many complications. In the same way, there are not adequate intra-hospital services such as hot and cold air conditioning throughout the year, which cause a lot of disagreement and sometimes suffering for patients and family. There are 11 operating rooms, of which we have one operating room on Monday, Wednesday, and Friday for scheduled surgeries. Unfortunately, the hospital does not have laparoscopy equipment for our service, except in very specific cases, so that most of the surgeries are performed open. The surgeries performed annually decreased in the years of 2020 and 2021 due to COVID. However, little by little, we have recovering for numbers the surgeries performed. Last year, we had a total of 544 surgeries. So far this year, we have a total of 464. Special surgeries are performed since more complex patients are handled that cannot be attended at second level. Surgeries in anorectal malformation, tissue, esophageal pathology, bile duct, lung and diaphragm pathology, spleen pathology, intestinal atresia, among others. Within the oncology clinic, all types of tumors and their resections as well as follow-up are handled. Among the most frequent are Wind's tumor, neuroblastoma, hepatoblastoma, thyroid cancer, Ewing sarcoma, Rapid sarcoma, osteosarcoma, mediastinal tumors, lung metastasis, among others. In Monterrey, we have a School of Pediatric Surgery with 10 graduate generations. In Mexico, the specialty is 4 years, and currently in our hospital there are 4 residents per year, giving a total of 16 residents in the school. During the year, we are divided and in constant rotation among several hospitals that are an important part of training. Our main hospital, which is the one you have just met, is the 3rd level and with the most complex surgeries in which we participate. However, we have other hospitals complementary for our education. 7 are 2 level and 3 are 2nd level. Our training consists of carrying out the activities of all these hospitals. Classes outside hospital hours that are normally in the afternoon and that are now mostly virtual, as well as 36-hour shift with the ABC system. However, on many occasions, it can be more hours depending on scheduled surgeries. This high specialty unit number 34, which has a cardiology and only specialties as well heart surgery and thorax surgery, where we perform heart and thorax procedures as part of our training. This high specialty unit number 23 is characterized by being the women's hospital, exclusive for specialty of gynecology and obstetrics, as well as the presence of pediatric neonatology and pediatric surgery. It is in this hospital where we train the most in congenital pathologies, where an average of 40 children are born per day. The Monterrey Maternal Child Hospital is the 2nd and 3rd level hospital which belong in the Ministry of Health, another of the public system in Mexico. Women and children are treated in this hospital for our training. Is one of the hospitals where we do have a laparoscopy equipment, all through in a limited way. The General Hospital of Sun, number 33, is the 2nd level hospital where we learn not so complex pathologies. This particular hospital is one with the highest volume of patients. It has an advantage that has a pediatric urology service, which is why it's played a very important role in our education. The General Hospital of Sun, number 6, is another of the complementary 2nd level hospital that no complex pathology. And the Hospital General number 17 is another complementary 2nd level hospital in which We participate and carry out the procedures and follow-up of the patients. The Puebla Children's Hospital is located in the state of Puebla in Mexican Republic. It is a second and third level hospital where they also have a pediatric surgery school. In this hospital, we go to the colorectal surgery service 2 months a year exclusively to learn about the pathologies and management in this branch. The Civil Hospital of Guadalajara, located in the state of Guadalajara, is the hospital that also has a school of pediatric surgery, and where we go 1 month a year and where we can observe a second and third level pathologies. We can learn about the different ways to treat a pathology and open our minds to more possibility for many children. La Raza National Medical Center is the second and third level hospital located in Mexico City, which is the capital of our country. We got to this hospital 1 month a year to observe the difference between the management of the patients and pathologies, just further expanding to our knowledge and practice. The Children's Hospital of Mexico is located in Mexico City and is other of the complementary hospital of our school, where we exclusively attend to pediatric urology service for 1 month a year. This hospital has highly specialized school in pediatric urology. This is where we see many of frequent as well as complex urology pathology and learn how to manage them. This is a statistic of surgeries performed by a pediatric surgery resident in their 4 years of study. We have the advantage that from our 5th year of surgery, the teachers allow us to be the main surgeons, as long as we demonstrate that we know about the pathology and the procedure to be performed. The continuation of the graph, where we can see that the central venous catheter placement procedure is the most frequent that we perform. Many upper endoscopy are performed as we have a large population of bottom cell and caustic ingestion. Each resident is training for these surgeries during their medical residency. These last statistics show the approximately surgeries performed at the 3rd and 2nd level, as well as the placement of vascular access by each resident during their pediatric surgery residency. However, to these surgeries, we must add some of which I could not obtain the statistics. Finally, this is the photo of the generation 2023. My classmates and I are graduates, accompanied by other residents and some of our teachers. Thank you.
Jorge, thank you very much for reminding us of the tremendous legacy that Mexican pediatric surgery has contributed to the world, and I just want to present you again on behalf of the Paps. Plenty of time to interact with the GAP fellows. We're ready for our next session, so we don't want to take time from our next session, but I'm just going to call on the committee and our previous fellows, Emiliana and Ricardo. You can just come to the corner here as the next session is getting ready to take a group picture, please. Thank you so much.
1, 2, and 3. Okay, one more time. 1, 2, and 3. Be in the report. Yeah, okay. 1, 2, and 3.
My name is Dan Ugarte from UCLA. And
hi, I'm Yu from Taiwan. The first topic is I will invite Dr. Wu Huang His topic is the laryngeal mask airway as an appropriate option in pediatric laparoscopic peritoneal repair, meta-analysis of randomized control trial. Please, Dr. Huang.
My presentation is about whether laryngeal mask is an appropriate device or option for pediatric laparoscopic peritoneal repair or not. There is nothing to disclose. As we know, during general anesthesia, both endotracheal tube and the laryngeal mask also applied to maintain the respiratory tract. Although both of them are thought to be definite airway during general anesthesia and emergent respiratory support, there will still some concerns about the laryngeal mask, such as the increased risk of aspiration, regurgitation, even more respiratory adverse events. But laryngeal mask was well used in many adult surgery, especially in laparoscopic surgery, such as laparoscopic cholecystectomy, which is standard procedure with a relative short operation time. But in pediatric population, although there is many studies show lower perioperative respiratory adverse event in laryngeal mask group, but just a few studies show the benefit in pediatric laparoscopic surgery. So we want to know the answer, so we conduct a meta-analysis to deal with the comparison laryngeal mask and the endotracheal tube in the pediatric laparoscopic peritoneal repair. This is our method. We focus on the randomized control trial that include patients under 18 years old, no language limit, and the final search performed in this May. The search database from PubMed, Cochrane, and EMAs. We use the mesh keywords as below to perform the searching. Our methodology quality appraisal used Robbins 2 is built by the Cochrane Library. We used to assessment the risk of bias in those studies. We performed statistic analysis by Riffman 5, also built by the Cochrane Library. We choose a random effect model and use the risk ratio to evaluate the outcome. This is our pre-SMART flow chart. Initially, we found more than 300 literatures about the topic, but after screening and elimination by improper patient, improper study, improper intervention, finally, we only have 5 randomized control trials to be studied. The table is show the characteristic of all the randomized control trials. We found the result. If we consider of the major perioperative respiratory adverse events, we will find, we can see there is no difference in incidence of laryngeal spasm and desaturation. Moreover, both groups show no bronchospasm and aspiration. In consider to minor PREs, we can see there is a lower incidence of cough in laryngeal mask group, but no difference in sore throat, hoarseness, or stridor. Furthermore, we also found in laryngeal mask group will have shorter anesthesia time and there is recovery time. Discussion about that. Previous study always showed laryngeal mask may increase the risk of aspiration and regurgitation, but in our meta-analysis study, we found that there is no difference between two groups. And the previous study showed laryngeal mask may increase the risk of the laryngeal spasm. In our study, also showed no difference between the groups. We also found there is more cough in endotracheal tube group based on past literature. It's maybe due to local trauma during intubation and tissue edema after surgery, and direct stimulation by endotracheal tube when WAG activation. If we talk about the shorter anesthesia time and the recovery time, it may reducing the cost in the operation room, because in the past the literature have proved it can be increasing the turnover rate, reducing the number of person used, reducing the amount of overtime payment. So it maybe have an economic benefit. However, our study had some limitations, such as all the including studies was held in a limited geographic area, such as Asia. There were relatively lower quality of the included studies, and the patient included is very relative older children in the studies. In conclusion, the laryngeal mask in pediatric laparoscopy in renal hernia repair had no high risk of the perioperative respiratory adverse events than endotracheal tube. So, and otherwise, laryngeal mask shorten the anesthesia time and the recovery time. It may be in the future to be the more efficient use operation room. Thanks for your time.
Okay, thank you. Romy Nelson, the United States. Very interesting talk and thought-provoking, because it's the level of depth of anesthesia that makes a difference, that you can do laparoscopy with LMA. Were they doing mostly propofol? Were they using precedents? I think that's a bigger concern. The airway stuff is not the major concern, it's the ability to do laparoscopy with LMA, but great talk.
Thanks for your question. Use general anesthesia for the hernia repair. So I want to compare that. So which one could be shortening the time and cause less trauma in baby's respiratory tract, maybe benefit the postoperative care and postoperative complaints.
Just to make it a little bit more interactive, who here in this room has used laryngeal mask anesthesia to do an inguinal hernia repair on any child? I have not. And of those, has anybody used it in a neonate? So when you say the older population, these studies, were they limited to patients over a certain age?
Yeah, maybe we're about 3 or 5 years old.
And so are you going to try it now in your institution?
Actually, my facility can do that, but some anesthesiologists refuse to do that, so we have to study for him or them to deal with that problem.
Okay, thank you. We move on.
Good afternoon, friends. I come from West China Hospital of Sichuan University. I introduce the total versus conventional robotic assisted polydocular assisted fixation in children. Robotic assisted polydocular assisted fixation has been applied in pediatric surgery in China. Compared to traditional laparoscopic surgery, robotic surgery utilizes the unique advantages of speedy imaging and flexible simulated human hand design, so reduce the difficulty of technique and improve the surgical operability and accuracy. I want to show the video.
You want to see it?
Yeah, that's like this. This is the robotic assisted procedure. I think it's easy for us. So the timing limit. The robotic assisted procedure works while the dural oscillation is completed through the the incision at the lower edge of the nerve. This procedure first. But however, for the older cases, even the obese children, in surgical procedure, including Roxy tracheostomy under total robotic assisted method, and which situation require this technique. Patients suffer from our department between December 2019 and February 2021 were analyzed respectively, and the data collected include the characters operative and post-operative details. Just like this, the Roxy procedure just under the laparoscopic, the robotic assisted. We performed is 50, and the traditional total robotic assisted is also 50 cases, but 19 converted to conventional procedure, and then the four include in total group is only 31. And about the in total group, if the age over 48 months, most of them can do procedure under total robotic assisted, and if the thickness of abdominal wear more than 1.3 centimeter, and the upper abdominal length over 10 centimeter, the total procedure can perform. And about the operation time, the total procedure is about 200 minutes, but the conventional procedure is quick, and only 170 minutes. So it's a significant difference. The logistical registration's result shows the risk factors age more than 4 years, TAW more than 1.3 centimeter, and upper abdominal length over 10 centimeter. So we conclude for polyductal cyst excision procedure, both total and conventional robotic assisted surgery are safe and feasible. It is recommended to perform total robotic assisted surgery in patients with age older than 4 years, and thickness of abdominal wear more than 1.3 centimeter, and upper abdominal length over 10 centimeter. Wherefore, others it is recommended perform conventional robotic assisted surgery because it is quick. Okay, thank you. Thanks for your listening.
So one question for you. Was the robotic platform too big? If we made the robot smaller, the stapler smaller, would it work?
Oh, try my best. For young baby, do robotic is difficult, but we tried for 5 years and get some mercy to justice the baby's body under anesthetic is can do, but I'm trying best to explain. So sorry.
Okay, because now we have to move on. Thank you.
Thank you.
Next speaker, please.
Good afternoon, I'm Adrian from Hong Kong and I'm presenting on behalf of my students. So, as we all know, the gold standard of CDH repair has been open repair. However, in this era of MIS surgery, there has been a gaining popularity among patients, among surgeons using laparoscopic repair. However, there has been controversies among the treatment, especially on the surgical outcomes of laparoscopic repair, and it has been criticized of having high recurrence rates in earlier reports. This is a meta-analysis published in 2010, which reported increasing risk of recurrence as well as a longer operative time in patients receiving MIS. However, we noticed that there has been more study published afterwards, which actually shows shorter hospital stay, early resumption of feeding, and less abdominal complication, and more importantly, similar recurrence rates. And currently, there has been limited long-term outcome on the CDH in the Asian region. And our study aims to fill this research gap by comparing the open laparotomy versus laparoscopic repair of CDH in our center. So this is a retrospective analysis of all neonatal patients who received CDH repair in 2002 to 2021. We compare the demographic data as well as surgical outcomes. And here are the demographics of our patients. We identified 64 patients who have CDH during this study period, and among which 52% of them had a prenatal diagnosis. And 13 of these patients have associated cardiac anomalies, which includes PDA and ASD. And for all of these patients, left side CDH remains the majority. And for these patients, MIS involved 35 patients, and open repair involved 29 patients. 2 patients was on ECMO during the repair, and all of these 2 patients actually belongs to the MIS group. And for the median age of the operation, it was 2 days of life, and the median body weight at the operation was around 3 kilograms. As for the comparative outcome of open versus MIS, the recurrence rate, time to recurrence, as well as the length of hospital stay was actually not significantly different between the open surgery as well as the laparoscopic surgery. And among all the patients who received minimal invasive surgery, 5 patients required conversion because of the persistent desaturation during the operation, as well as difficulty in reducing the contents into the abdominal cavity. And gastrointestinal complication happened in 2 patients in the open repair group, and which mainly intestinal obstruction, and there was none in the MIS group. And we also look into any factors of the learning curve, and as in terms of mean operative time. And we compare the initial 10 cases with the open operation, which there was significant differences in terms of the mean differences in the operative time. However, after the 10 cases of operation, you can see that there is actually no significant differences in terms of the mean difference of operative time as compared to open surgery. So, in conclusion, we find there was no significant differences in recurrence rate, time to recurrence, or median length of ICU stay between the open and minimally invasive surgery. We acknowledge that our sample size is small, which may weaken our analysis in terms of statistical power. However, I hope with this study and my presentation, the floor will join me to agree that laparoscopic repair is a non-inferior surgical option which have good wound cosmesis and actually could avoid gastrointestinal complication when we compare to the open repair of CDH. To conclude my talk, I would like to invite all of you here to Hong Kong next year in April, and we will be the joint Paps as well as the AAPS meeting, and I'm sure all of you will be very happy and as you do in the Bali meeting this year. Thank you very much, and I welcome any questions.
Thank you. Go ahead, Lars. Can you give me the difference in both the groups where patch was used and then the rate of recurrence?
Yeah. We acknowledge that for patients with patch, we did analyze that and noticed that in our current this study this side. But I think with that, we can look into that and include that in our future analysis. Thank you.
Very, very important that we compare two groups the same. I didn't notice that you had put defect size between the two groups, were they the same or not. And then you only had 3 patients on ECMO. We probably do 30% of our children with repair on ECMO, but they're all very large defect patients. And it makes it very difficult to move to the operating room, even if we were so inclined, which we're not. But we do stop comparing the small.
Thank you for the defect size or the classification of defect size. But admittedly, for this study, was we haven't included that in the final analysis. But I think that it is worthwhile for us to consider that. And for our 2 experience of performing a CDH repair on ECMO, it was actually quite a good experience because the patients were rather stable during the operation. And I think the surgeon, at least the surgeon himself, enjoyed the operation because it was a really smooth operation.
Any question?
Thank you. Good afternoon, everyone. My name is Tan Kunbi, and I'm from Fujian Province Hospital, China. It's a pleasure and honor here with you to share our team's work and about work on pediatric thoracic lobar surgery. Congenital pulmonary airway malformations are the most common type of congenital pulmonary dysplasia. However, how to actually define the scopes of the defect and the plan of surgical rejection is still difficult. 3-dimensional computer tomography reconstruction and endosinal green fluorescence staining have been widely used in the localization of adult lung surgery, but there have been few reports in children's lung surgery. Our hospital tried this method for children with CPAM surgery. This is one of the cases. Based on the 3-dimensional CT, we can determine the extent of lung segment section and the level of bronchus, arteries, and veins. This is the surgical procedure. This one is we expose the interlobar pulmonary trunk. And then we exposing the artery. Then we clamp and degazen superior artery. And then we cut off the segmental bronchus. Endosinal green reverse development, and the non-development is the up-left lower lung segment. And then we demarcation the line. And last, we excise the up-left lower lung segment. And the results, we found 3 months after surgery, a CT scan was performed and non-residual lesions were found in all patients. 3-dimensional CT combined with endosinal green fluorescence imaging can improve the accuracy and safety of pediatric congenital the airway malformation surgery and had a good clinical application value. Thank you.
Thank you. Please. No?
Good. Friends, I come up back again. I just showed my experience about the Da Vinci robotic assisted conductor assisted resection in children. Experience sharing about the 200 cases in the possibly 5 years in a single center. The main treatment about the conductor assisted is including open MERCID, laparoscopic MERCID, and robotic procedures. Open surgery now seldom choose because cannot meet the increased aesthetic requirement from the family. And the learning curve of the laparoscopic surgery in London, about 37 cases in China. And if complications such as bile leakage and bile duct stenosis are increased compared to the open surgery. So the aim is to explore the clinical efficiency and the safety of robotic assisted conductor assisted resection compared with the laparoscopic surgery in children. The data of the case just including peri and post-operative details who under Da Vinci robotic assisted conductor assisted resection in our department in the past 4 years, who connected about 200 cases were connected and analysis. The result just showed the operation time in laparoscopic group is more than 220 minutes. Robotic group we can quick and about 118 minutes, and they converted to open surgery. In laparoscopic group, they have 6 cases, about 3.2%, but in a robotic group, until now, no case converted to open. And the post complication in laparoscopic group is about 18 cases, about 10% have complication, but in robotic group, it's better. So I think the robotic procedure were suggesting because the effective shorten the learning curve. In robotic group, this is our group. The learning curve about 14 in cases, and this is my friend's department about the laparoscopic group. The learning curve about 37 cases, so were short the learning curve under robotic. And under robotic, we can more thoroughly remove the cyst at the distance and the proximity, and we can do it thoroughly. Just shoot like this. We can cut under the proximal and we can cut very smooth. And if we meet the mutation situation, we do under robotic more calmly, I think. This mutated left and right hepatic ducts, and this is variant right hepatic artery and the cystic duct, and this meets the accessory hepatic duct, and there's several infections lead to gangrenes and perforation. If it is this situation, sometimes under laparoscopic way, convert to open, but under robotic we can do. Sorry. Conclusion. The emergency and gradual dissemination of Da Vinci robotic-assisted surgery provide a safe and reliable operation for treating pediatric colon-duct-assisted, offer a short learning curve and no complication and faster post-operative recovery in pediatric patients. Thank you.
Thank you so much. If there are no questions, we'll move on to the next speaker, Dr. Zhu Guang Wu, on medium and long-term technical.
Okay, thank you. Good afternoon, everyone. My name is Wu Zhouguang. I come from Shenzhen Children's Hospital. Today, I want to talk about the medium of and long-term efficacy of laparoscopic surgery operation. We analysis involve clinical data from 308 children who underwent laparoscopic surgery operations for biliary atresia in Shenzhen Children's Hospital between November 2011 and December 2020. These children were taken into Group A and Group B based on timing of collaboration with liver transplantation team and initiation of the stooled color card screen program. The operation date and instance of cholecystitis and post-operative jaundice clearance rate and 1 year and 2 year survival patient with native liver and liver transplantation was recorded. 87 cases underwent laparoscopic surgery operation surgery from 2011 to 2015 and were in Group A. 221 patients received the surgery from 2016 to 2020 from Group B. We analysis results difference were observed between the two groups in terms of the age of operation, jaundice clearance rate, and 1 year or 2 year survival rate of the native livers. During the follow-up, 159 out of 308 children developed cholangitis, and the rate of jaundice clearance was 15.5%. The 1 year and 2 year survival patients were latest livers rate were 18.1% and 52.6%. And 135 patients underwent post-native liver transplantation. We compared our results with the traditional open surgery in other surgeries in China. The results are shown in the figure. Okay, we identified the stool-colored card screen program as a kid, milestones are beneficial and earlier diagnosis, thereby reduce the age of time of surgery. Laparoscopy Kasai operation for treatment of beer near anesthesia is safe and feasible, and led to long-term clinical result is satisfactory. Thank you.
It's a very impressive series. Congratulations on your results.
Good afternoon. Greetings from Jitma, Pondicherry, India. Next slide, please. Yeah. Next slide. I have no disclosures. Even though the first pyeloplasty was described in 1939, about 80 years later, we are still transitioning from open to laparoscopic to robotic. In 2002, the first robotic pyeloplasty was described. These are the positioning. It is similar to the laparoscopic procedure, oblique positioning. That's on the children. We are using exclusively the Da Vinci XI system. There are midline straight line placements of 3 robotic ports and 1 assistant port of 3 mm. The minimum distance between the ports used is 4 centimeters, usually between 6 to 8 centimeters. The patient card comes in from the ipsilateral side. Just to show that even with the regular instruments, we can use a 6-0 vitral suture of a 9.3 mm needle. We don't require advanced robotic instruments. We use, to minimize, since we do not have haptic feedback, we minimize the handling of both the suture is handled gently and minimize the handling of the tissues by using the pelvis as a handle. And so you can see the pelvis is used as a handle and not the ureter directly, or use nudging or open the pelvis to place the suture so that we do not traumatize the delicate infant tissues. The advantages of the robotic are being well described in many places. I do find that the camera being used by the surgeon himself is also a major advantage. Cinching of the suture to make it sure it is watertight, and that is a suture. In the department, we have analyzed our first 100 cases, 34 of which were infants less than 1 year of age. There was a 68 to 32 male to female ratio, and the right to left was slightly more common. We also did a few complex cases like redo pyeloplasty, ectopic kidneys, giant hydronephrosis, malrotated kidneys, and 1 case of duplex in a lower moiety. The consult time was a median of around 133 minutes, and in infant it's slightly longer or shorter, just a few minutes difference. Among the cases which took more than 2.5 hours, 4 of them in my personal series, they are usually in patients who have more complex disease like an ectopic hydronephrosis like in the pelvic kidney, or a giant hydronephrosis where more suturing is needed. Coming to the outcomes, bladder catheter, initially when we started we were doing from open to laparoscopic to robotic. We kept it for longer, but at the current time, all cases inclusive, it's about 1.7 days. Half the surgeons are removing it at the end of 24 hours. The others are removing it at 48 hours, that is one of me. But I do not place any drains. Drains come out at the end of 2 days by surgeons who have kept the drain. DJ stent usually comes out by 6 weeks. The hospital stay is 2.8 days median. Currently, that's for all cases. Currently, it's down to 2.2 days. We had some early complications, 3 in number. One of which had a prolonged leak because of migration of the DJ stent and had to be managed with a PCN. which was kept for 6 weeks, and the DJ, which had migrated up to the pelvis, was removed when the PCM was removed after 6 weeks through a nephroscopy, so it didn't require any other intervention. Prolonged leak in 2 more cases were managed conservatively and settled on their own. Recurrent period, out of these 100 cases, 89 have been evaluable, that is, they have completed at least 6 months post surgery and have had an ultrasound and EC scan, nuclear medicine scan. And UTIs were 11 in number during the DJ stent placement, and after removal of the DJ stent, 2 more required admission with antibiotics. These are the babies doing well after 24 hours after the surgery, quite playful, which we do not usually see after our open cases. These are the pre and post-op results of the ultrasound, and this one, just one of them shown here. So, scars, and coming to the conclusions, I feel the robotic platform is an enabler of complex advanced minimal access surgery. The learning curve is relatively short compared to minimal access surgery, and good results are possible safely at all ages, including infants. Our youngest is a 4-month-old, 4 kg baby, and they are also giving good results and can be performed safely even in complex cases. Cost is the white elephant in the room, or the elephant in the room, and they are likely to come down with more entrants from the market. Thank you.
Thank you. Yes, we have a question.
Excellent results. My question is, what is the reason for your short learning curve? And secondly, you are a big teaching institution. Are these all cases done by the attendings or consultants, or what sort of proportion are done by the trainees? And if they are done by trainees, you are doing a great job, and we all need to learn from you. Thank you.
At present, the robotic platform is available only for the attendees or the consultants, as we call them. So the residents are not taking part in the robotic surgery. We are now looking into how to get the residents into the robotic training program. So these are all done by consultants, not by trainees. What is the other part of the question?
So you answered both the questions. I was just saying that your learning curve is very short, because I practice urology and surgery both, and these are excellent results. But do you think if the trainees start doing, they will deviate from this?
Except for the duration of surgery, I think all the rest should be the same, except for the duration of the surgery, which they will reach these numbers in a short time. I have not analyzed, depending on the 4 of us consultants who have started have not trained at the same time. We have done it. I did it first, and then my next colleague did it next, and we both trained the other 2 colleagues in the department. So all of us are not at the same level of learning, but all of us are reaching there fairly fast.
Thank you so much.
Thank you very much.
Good afternoon, everyone. My name is Chen Jianglong, and I'm from Fujian Provincial Hospital, China. And it's a pleasure and honor here with you to share our team's work about on pediatric urology, robotic surgery. And this is the content of our study. And as we know, vesical urethral reflex is one of the most common congenital anomaly of the urinary tract in children. And there are various surgical procedures. And in recent years, minimally invasive is the trend of surgical innovation. And MIS is very beneficial to children and gains more and more population in pediatric surgery. And here, we apply a new way of trocar placement in pediatric robotic assisted leech urethral reimplantation. And the main of this study is to observe if the new way of trocar placement increase the complexity of the surgery and the short-term effects. And this is this is a retrospective observation study. And including a total of 33 patients and 20 patients in Singapore class 1 group and 13 in multiple group. And all patients, the characteristic preoperative data, operative data, and post-operative and follow-up data are collected. Here is the new way of trachea placement we use. We use a single port, have four channels, and another 8mm robotic trachea in the SR group, and a 3mm trachea, robotic trachea, plus a 5mm assistant trachea in the MR group. And here is the main steps of the surgical procedure. We open the refolding peritoneum and separate the ureter from here. And then a thin, soft hose is used to pull the ureter, and which could avoid overclamping the ureter by robotic instructions. Then the ureter was embedded into the muscular layer of bladder by a fixed ratio. And here's the result. This table demonstrates the characteristic and preoperative data of SR group and MR group. And in this table, we focus on the preoperative BCUG grade and the DRF. And both of these two data showed no differences between two groups. And table 2, we show the intraoperative data, and this table demonstrates no differences between the two groups, and only the time of AP show differences. And in this table, we show the post-operative and post-operative and follow-up data, and we can tell that post-operative data, post-operative BCUG grade of these two group patients all decline to grade 2 or grade 1, and patients' parents are more satisfied with their scar outcome in the SR group. And figure 3 show the BCUG of two groups before and after operation. And in this clinical respective study, we found that SR in robotic assisted leach grader ureter reimplantation is safe and has a comparable short-term effect as MR, and it has a better cosmetic outcome of surgical scar. Thank you very much for your kind attention.
Are there any questions? Please. Shananda Singh, Nottingham, very good study. I'm just curious, you had grade 3 reflux which you have gone before, or how many grade 3 you operate as such? Because I don't operate on grade 3.
You mean injection? We don't try this way of treatment. We do the vesical ureter reflex by from early stage we do it as open, and later we do it by the laparoscopy, and then now we can do it treat most of patients with the robotic laparoscopy weight.
Any question? Okay. So
to our Paps family, these are just a few. We had a special presentation for Dr. Surubi yesterday. Some of the things is hard to know. If you know somebody that we've lost this year, even spouses or accompanied persons, please send me an email and we will acknowledge them in future meetings. Okay, Lee Carlo. Where's my friend Lee Carlo? He's gone. He was just here. Okay, we're going to skip Lee Carlo. Maybe he's trying to get dinner ready for us.
Okay. I'll let him come back to it. All right, Bill.
Great. So I'll start the treasurer's report from where we left off last year. For the keto meeting, total income's about $91,000. That's mostly registration, and we got $5,000 donation from Kids OR. Hopefully we can continue that relationship. Joe's working on that for next year. And total expense about $115,000. So we had a net loss of $23,000, which is way better than what we were going to. We were really hoping we were going to be the deep hole. So turned out that it was not too bad. In terms of what we spent it on at the keto meeting, I thought I'd just at least have the pie chart there to let everybody see where expenses went to. Most of that's the hotel. The menu was about 68%, which makes sense. But in terms of academics, which includes the GAPS program, the JPS lecture, the Paps prize, which I count as academics, comprised about 16%. So I think we have been pretty responsible in terms of spending our money. So the income for 2023, most of our income is from membership dues. The Stripe system that Sarah set up from a membership committee, which has been very, very helpful. For this past year, we collected about $18,000, and those payments are very easily trackable through the account. So big thanks to Sarah. And we actually made an investment income of $3,400 some over this past 8 months, and I'll talk more about the investment. But our total income was $21,839 this past year. Expenses. So I just kind of separate them out in different categories. This is the administration, so I kind of lumped a lot of this into this category. So we do have to pay a monthly fee to Stripe. Comes out to about $220 for the 8 months that, or the however months for this year. It's hosting to the main site, the website hosting, payment to the past treasurer for some expenses, Sarah for the membership expenses. The one we were paying monthly fee for the checking account, since we converted to a business checking account, we no longer need to pay that. In fact, we get to wire money to anywhere in the world for free using our checking account. And everybody forget, California, we are registered in the state of California in the United States, and we got to pay $100. And then we had other expenses. Education, we paid for APSA, the NAT, $5,000 as a benefit to our membership. The abstracts management and the conference app. So abstract submission and the app that you use for this meeting, they are $3,600 and $16,000 respectively. Comes out to about $25,000 under the education category. Every year we spend about $1,000 to prepare the tax for the U.S. And this is the front, the Bali meeting a few months ago. Comes to about $49,000. So in terms of how we spend the money this past year, most of it, the bulk of it obviously is in the advance, 63%, education 32%, and administration actually only about 2%. So I'll continue to track how we use our money in terms of each category, so we don't just spend a lot of money on categories that doesn't further the mission of our organization. So we spend about $77,000. Hopefully we'll get $49,000 back from Lee Carlo and more one at the end of the meeting, and we will add to the total amount that we have for our organization. So this past year, did a lot of reorganization of the finances. We apparently have different accounts scattered throughout different companies. We have some investment account in Vesco that was apparently established many, many years ago. Nobody really knows who actually opened the account. So it was quite difficult to close that. We closed it and then transferred the money to the checking account. And big thanks to John. I don't know where John Meehan is, but I sincerely thank him for making a lot of money for us, starting from the Seattle meeting and also the 2 virtual meetings. And we were able to, he was able to transfer to our organization account for more than $132,000. So we owe a big thanks to John. And apparently we have a PayPal account that's got $17,000 in there too. So those accounts are all closed, and they are now in our business checking account through the Chase Bank. So we have about more than $200,000 in there. And the reason that that amount is there is that if for whatever reason we need to run a meeting from scratch, we have money in the checking account that we can immediately access. And the rest are in this infidelity, in various investment tools. FAGIX is, thanks to David Tuggle's recommendation, we've been earning 6.91% return. And then the other 2 essentially are just money market, earning close to 5% return. So about another almost about 182,000 are in the investment portfolio, and I'm hoping that will become essentially the endowment that we continue to make money and support our mission. So just the last 8 months through these investments, we made about $3,400. So hopefully that will continue to grow. And just for comparison, the GAP program last year, the expense was about $6,000 or so. So the idea is that maybe we can even make the GAP program essentially self-sustaining. Our total assets as of August 15, 2023 is $327,000 plus whatever Lee Carlo is going to give us at the end of this meeting. That's it. I'll take questions.
Per year. I'm suspecting that the old-fashioned booklet will be a hell of a lot cheaper.
No. I paid $20,000 when I did in Australia. I made $50,000 profit in spite of that. But the books are very expensive unless it's made in China. In all other countries, the books are very, very expensive. You have to set everything. There's no way they can go back to books.
And thank you for bringing that up, Kevin. In fact, we fired him at other questions.
They didn't charge us before, only now they are charging.
Okay.
Thank you. All right, Lee Carlo, the man of the event. Lee Carlo.
Thank you, everybody. Thank you for still being here with me. So I would like to give you a brief summary result of our meeting for this week. So this is the registration before early bird. As you can see here, realization members was 97 people, non-member 40, ASEAN pediatric surgeon 35, trainees 70s, 1 special discount, and 44 accompanying person. And after early bird, but not on site, realization plan members, non-member 23, ASEAN 11, training 22%, no special discount, and 8 accompanying person. Well, this is the total participants of our meeting member early target 75 and the realization 109. Non-member 50, realization 72, ASEAN 25, 51 realization, training 50, and realization is 93, almost twofold. Special discount only 1, accompanying 25, and realization 57, and total of the attendees for this meeting 383 persons. I think it's normal. Again, it is not too up to date, but this is what can I compile lunch. Japan is still number 1 who sent the pediatric surgeon to every meeting, every Paps meeting. And however, Indonesia is number 2. Thank you very much for Indonesian pediatric surgeon. I hope in Hong Kong we can number 1. I don't know, but I think Hong Kong will not accept it if Indonesia number 1. Or attendees. And then followed by China 39, yes, United States 32, India 9, Hong Kong 6, Taiwan 19, Korea 18, Australia 9, New Zealand 2, Malaysia 3, Singapore 4, Brazil 1, Mexico 1, Canada 5, Russia 2, England 3, Thailand 2, and Belgium 1. Maybe there's some countries that I haven't. Tunisia, yes, right. Tunisia 1. Tunisia 1. I know. Where else?
Austria.
Malaysia?
Austria.
Oh, here Malaysia 10. Yeah. Why there's a difference here? Because some of you didn't put when you fill your registration, you didn't put your nationality. You come from where? That's the reason why I can't put where you come from. Yeah. Vietnam. Thank you very much, John. I forgot that. But John will compile it this evening. Don't worry, ladies and gentlemen. So that's that I can report. But about the, I think I will report to continue the report of our expenses, because it's still working until tomorrow. So we don't know how many expenses that we should come out from the committee. Thank you very much.
Thank you, Ricardo. I thought dinner was free tonight, no? No.
Right, thank you. Just a few slides to summarize the work of the population committees. And I'm presenting this on behalf of American Windows, who sometimes come to here this time. And first, I would like to have a big thanks to all the members of the population committees, because they have done an excellent job. This year we have 26 members with 4 new members. So this year we have received a total of 59 submissions. So each paper was reviewed by 3 reviewers. So before the meeting, if all the reviewers accept or with revision, then the paper will be accepted. And say if all the 3 reviewers reject the papers, the paper will be rejected without discussions. So in the meeting, we have 29 papers to be discussed because of disagreement between the reviewers. So after 3.5 hours lengthy discussions, we have sorted out 5 papers that were added to the acceptance pool. So at the end, we have 22 papers accepted for the publication in JPS this year. And as you know, we have the Assistant General's JPS open. So Mary and I are going to select some papers that could not reach the standard of publication here, but recommend them to submit to the JPS open. As you know, for the past 2 years, Mary and I have been writing editorials for the past 5 winners about the articles they have submitted in the JPS, and this year we'll do the same. And also work with social medias to promote our publications in social media to have more attentions. And so that's all I want to report about PopCount. Is there any question or comment? If not, then I will pass the poll to talk about the scientific committee of this. The report from the scientific committee, a proper on-site meeting after the last two COVID Zoom meetings and the hybrid meeting in Quito. So we have 419 submission abstracts, and as usual, we like to reject as little as possible. So we only reject by 20, that's about 5%. And they were withdrawn, 34 have been withdrawn, but the number is increasing. I'm still getting emails today for people who are writing to say they're not coming. So we can see so on the program it's about 364 abstracts. And during the last few days, we've seen a lot of no-shows. There's about at least 25 no-shows, which we have to see about that tomorrow. And we may need to do something about that in the coming years. Countries represented from China, USA, down to Indonesia, Philippines, and Russia. The topics submitted are on the figure on the right. This year we are accepting 25 posters a day, so 100 in total, so 25 every morning. Quick shots, we have 2 rooms going concurrently, a little bit early in the morning at 6:30, and there are 144 talks in the mornings. And then oral presentations, we've increased from 13 to 15 sessions, with 2 sessions in Paps, Quito, 2 sessions on GI, and 2 sessions on hepatobiliary. And then we have a 15 video session during lunch. We have quite a few long full orals of 5 + 2 minutes, and most of them are short oral, 3 + 2 minutes. So this is a summary of each category with 45 full orals, 91 short orals, and a total of 136. And then we have no-shows of up to 4 per session, and then we have to discuss whether they will be penalized in the next year or 2.
I don't know.
Yeah.
It's just submit abstracts and not show up. No other organization really accepts that. And although you don't reject much, a lot of these withdrawals could have been because people felt their abstract needed to be in a different session or wanted a podium instead of a poster. So it does have consequences for people who submit abstracts and then withdraw them. So I think, in APSA, if somebody does that, they're not allowed to submit abstracts for 3 years. And maybe it doesn't have to be as harsh in TAPS, but I think there's got to be some consequence.
Yeah, so I've been doing this the last 3 years and seeing this happen when I helped Bill, when I was doing the conference app for the first 3 years we had the conference app. There's a lot of this. It's about 10% every year. It's pretty consistent. And we have not had any penalties, but I do think that we need to do something because it's becoming more of a problem. And actually this year, now that we've rebounded from COVID, very excited to see a great number of abstracts. And thanks to everyone who encouraged all their colleagues to submit. I do think that we do need to move towards that. At the same time, we have to be cautious about not hurting ourselves in the submission process because it is the lifeblood of the meeting to have enough participants. So one of the things that we can do to help combat this is to take the people, there will always be no-shows. As much as we don't want it to happen, there will be no-shows. But it's nice to upgrade some of the quick shots into the regular presentation as we know those things are starting to occur. So that's one thing that everyone can keep in mind as you're letting everybody know about this discussion, that even if you get a quick shot, there's a chance you may get moved up to the higher level.
Thank you, John.
Thank you, Paul. Thank you for running crazy together every morning. So, as a local committee, that I would like to ask, because every participant stage that show their poster, they always ask us about who will be the juries for our posters, who will be our, who will be in charge for this. So I think we have to think about who will be the committee in charge for the posters or e-posters. Thank you.
Right, so the posters, each of them get more than one emails about whether they are paper posters or e-posters, and they get a number. And usually, when we tell them, they put up early 6:30 in the morning and take them down by 6 p.m. Those instructions are very clear, including the oral presentation where there are 3 minutes or 5 minutes both. They've been in several emails reminding them.
I mean, there is no juries or committees who ask for their posters. That's what I mean. Because every time they have put their posters in a place.
Oh, you mean panelists?
Yes, the panelists.
They usually know for posters just for display. Usually.
Okay, thank you. Because we have to clear about it.
Yeah, just to clarify, the quick shot replaced the oral poster that we used to do. So since Christchurch, which was Spencer's idea, a brilliant idea, to change
people, especially because this year the meeting was in September, and usually our meetings are in April, and if you don't get selected here, there are 5 other meetings to present. So I think it is too harsh at the moment. And also, if you run a meeting, you need people to come. We need more people to come. So I'm never I won't agree for punishing anybody.
Okay, thank you. I'm going to respectfully disagree with Ryan as well. The problem is that once people have accepted it, then there are a lot of things that flow through there. Not just the meeting itself, how it's organized, but the expectations for numbers of people at meals. I mean, it flows through the entire meeting. And there's financial implications for the organization when people don't show up. So, and importantly, that most organizations do this. It's not just the presenter, it's the senior author who is also not allowed to submit for whatever we decide. But I'd like to propose that we make that a formal proposal, and just because it is Paps, not Apps, that maybe a year instead of 3 years, but it should include the senior author, in my opinion. But I think we have to do something about that.
And just to point out one additional thing, you're taking the spot of somebody who could have presented. And I think that's the worst part of it all.
That's exactly what I think. The problem is we have, four papers that were in that last session.
That's right.
That's 4 people that could have presented or could have upgraded from a short oral to a longer presentation. And I think you're right, Kevin, that not only the author, but the senior author should take the hit. Because they're the people that are driving it.
The event pilots actually been updated daily by Carol and I until before the presentation. So if they email me the day before on Sunday, I take them off. So these are the ones that didn't bother to write to me about it.
I think we just have to be cautious because Kim Gilson, who's my very anally retentive psychologist, who has gone through all of her emails, because she was absolutely mortified that she wasn't here. We only knew about it because Hannah, our student, said, "Oh, Kim's presenting tomorrow." So the email, she didn't get the email to say that she was presenting the full oral. So the presentation that I gave the other day was she then put together a presentation very quickly and then I presented it. So you just have to be mindful of the fact that there are some people where the email might not have got there where it wasn't.
Yes, so for that I have 2 points to make just previously when I did the program. So, and as I've started to put our Chinese colleagues on the spot, but usually the way that it works for their hospital is that you get acceptance and then you apply for funding. So if you don't get the funding, you kind of can't go. So they need to get the acceptance first. And what I've done in the past is basically there's this confirmation system. Once you're accepted, you've got to write back and confirm. And if you don't confirm, that's it. You're out. And so you make that very clear. You send repeated emails to them, and they don't confirm. You just take them off the program, and that's it. And then that way, hopefully, we don't penalize and allow our colleagues in other countries that have different way of obtaining funding to come and not be penalized. If, next year they can get the funding.
So on that point, the whole process of applying for funding may may be quite long. So some people may write to me last week say they didn't get the funding, so they cannot come. So that's the last thing as well. We did send out confirmation emails, asking them to confirm, but not all of them do that. So if we take them off, all of them off completely, we will probably end up with a much smaller program than we expected. That's the downside of it.
You have 2 weeks before the start of the meeting to say whether or not you're coming or not. That gives all of our colleagues time. And then it also gives you time to upgrade somebody from the lower level up to whatever so they can prepare. So I make a motion to make a 2-week deadline on this and then a 1-year, you're out kind of rule.
I think that's something they're debating to decide. I don't think that's a membership decision. So we don't need to vote on that. I think that's a great suggestion, and I think they're probably inactive. But Dr. Kim.
May I propose it? And I sympathize with the motion, but I'd like to provide the option of explanation by the authors, and if that's accepted as a legitimate explanation, then it shouldn't go to the punishment, because I won't want this to be just digital, yes, no. So if there is there are mitigating circumstances that the authors can provide, then I think we shouldn't just say the rules now say that we will have to sanction you for a year. So I'd like to propose the modification of giving the chance for authors to respond, and if a satisfactory explanation is forthcoming, then the sanction does not apply.
Thank you. I think both the 2 weeks are coming, so they give an explanation about travel plans, about sickness, about pregnancy, and others. But these are the ones, the no-shows are the ones who don't write to us. That's why they stay on the program, and we won't know about them. But I think we will take those into consideration for the next year.
You are going to do anything.
All right, so I don't want to repeat everything. How many people in the room were here for the GAP presentation? Because I really don't want to repeat them. Okay, not a lot of people. So maybe I will have to repeat myself a bit. No, so first of all, it's been really a privilege for me personally to co-chair the GAP program for the last 7 years. As I said in the presentation, Jim Warden was a big influence on me early on, and just keeping his legacy alive and remembering him has really been very emotional for me personally, and also a real privilege, and also working with Marilyn these last really 7 years. We were supposed to be here for 5 years, but because we had 2 years of no program in person, we finished 5 years, and then we now turned it over to Arturo and Grace. I don't know if Arturo is still here.
Yes.
Oh, so if you guys maybe stand up just so people can know who you are. They are the next co-chairs of the GAP program for the next 5 years. So welcome aboard. So maybe I'll just go back here. Cruise the day before I came. And like I mentioned, they have now 18 grandchildren and 10 great-grandchildren, and this is just a small part of her family. We've had 43 GAP fellows. I think we'll write something for the Paps issue to update the GAP program, and especially as we're moving to new co-chairs, and also to continue to remember Jim Warden. I recognize Cynthia and Marilyn for the work they've done for the last 15 years. I mentioned that there are some other programs that are sort of like little gaps. So Arturo is hosting some residents from Ecuador. It was just part of the Paps Global Surgery legacy. This is the makeup of the committee going forward. There are no specific number of members on the committee, so it is open for anybody. What we wanted to vote on was two things. One was that there was a bylaw that membership in this committee would have to be approved by the board, and I think it's the only committee where this is required, if I understand. So we wanted to have a vote, maybe because we want to take the program over. Okay, so the votes are coming up. The other thing is that we wanted to be able to have people serve for a second term, because right now, again, the bylaws say 1 year term of 3 years. So some of the people who've been active, we wanted them to be able to serve. And of the people here, Shin Miyata from St. Louis, USA is a new member. Shin, maybe you stand up so people can recognize who you are. So welcome to the GAP committee. And it's also great that Dunia, who's now actually one of our research fellows in Montreal, is actually serving on the GAP committee now. You met our two fellows. One of the things we discussed is doing away with the stipend that was given the fellows, because there's not a lot of expenses, but since the financial situation is good, to actually have a scholarship attached to this, because some of the fellows do have to leave their practices, and for some of them at least that does mean there is an incurred expense in leaving your practice behind. So there was a proposal to actually make add a $500 scholarship to the program that the fellows would actually receive as a scholarship. I think that's pretty much all the new stuff for GAP. Thank you.
Thank you. Okay, we have lots of new members. Thank you, Sarah, who's done a great job of kicking it.
All right, lots of slides to get through. This is our quick agenda. So in terms of our current membership, we have 287. This is up from 248. Of those, there are 208 that are active. The remaining, so the remaining for that 375, those are the ones that are all expired or lapsed memberships, I should say. But the number of active members has gone up from 181. The number of senior members has gone down. And just so you know, if you are over 65 or you are retired, you are eligible for a senior membership that doesn't require any dues payment yearly. But you do need to press the renew button so that you can update your profile and you can contact you again, because there are so many people who we can't contact, and we just don't know what's really happening to them. And so it would be good for us to get in touch with you that way. We have one honorary member, and we have up to 23 trainees now, which is fantastic, of which most of them are actually from Indonesia and Ecuador. And so what we've tried to do is to make things easy for people to transition from a trainee membership to an active membership. What I'll kind of automate is basically an email that gets sent out to them around the time that they've finished graduating, because you really do need to be practicing as a surgeon for a year after completion of training before you can actually become an active member. And then what we'll do is we'll just have their kind of proof of board certification or whatever proof that they have, so that we can just change them over to an active membership at that time. So the 240 lapsed memberships, and so the local organizers are supposed to be kind of cross-referencing who has actually come to the meeting with the member discount rate and who has not actually paid their membership, so that we can hopefully catch some of those people at that time. I have asked, or I will ask again, that the committee chairs check the committee members to make sure that everybody is also up to date. And if members do not renew their memberships for 2023 and 2024, because by the end of this December, we will start to leave people off this list to clean things up. And this is at the very bottom of the login screen. You should see renew membership as active member, trainee member, or whatever. Your current membership expiry date is such. You have to press that renew button. If you don't press the renew button, you have not renewed anything. You've only updated your profile. So this is the section for the new memberships that we've gotten. So we've had applications that have been approved. So 25 active members, as well as 22 trainee members of each of the countries that have been that they've come from. And this is just a visual depiction of that. So that's pretty exciting that we have so many new members from Indonesia, but kind of all over the world. And we actually have one from Qatar as well, who wasn't able to make it to this business meeting. And so one by one, the ones that we actually know who have actually come to this meeting, I'm going to call them up to the stage. Dr. Dunn and Kojin are going to hand out their certificates, and we're going to get a good picture of them at the end.
Sarah, there was a question at some point. You do not have to be in a Pacific Rim patient.
No, so the geographic numbers, so the ones who are around the Pacific Rim, those ones can apply anytime after 1 year completion of training, of course. But the quote-unquote invited members, those are the ones who, they don't have to live in the area, but they have to have had attended at least one meeting in the last, I think it's 10 years or something like that. It is kind of all in the requirements section of the application, but we have in the last several years kind of narrowed down the number of documents that you do need to submit, and letters and sponsors and whatnot. Everything is much more straightforward, and we're just trying to be more inclusive to as many pediatric surgeons as we can. So here are the active members. The ones with the red star, which unfortunately is blending into the red background, they are in attendance here, except this one because she actually wasn't able to stay for the but Dr. Alan Zari from Doha, Qatar, Dr. Blakely from Nashville, USA, Dr. Chen from Wenzhou, China, Dr. Fujino from Tokyo, Japan, Dr. Ha from New Taipei City, Taiwan, Dr. Ho, Dr. Ho from Seoul, South Korea, is Dr. Ho here? Dr. Huang from Taipei City, Taiwan. Dr. In from Seoul, Korea. Dr. Unue from Toyo Akes, Japan. Dr. Jung from Daegu, South Korea. Dr. Miyata from St. Louis, USA. Dr. Mueller from Palo Alto, USA. Dr. Nam from Kuala Lumpur, Malaysia. Dr. Namjoon from Seoul, South Korea. Dr. Pilkington from Toronto, Canada. Dr. Purnomo from Sleeman, Indonesia. Dr. Saeki from Hiroshima, Japan. Dr. Salinas from Guayaquil, Ecuador. Dr. Surya Alam from Klaten, Indonesia. Dr. Tanaka from Fukushima, Japan. Dr. Yang from Taipei, Taiwan. Dr. Yoon from Jeongbuk, South Korea. And then these are our active members, and then the next batch will be our training members. Dr. Ali Moeden from Bandung, Indonesia. Dr. Alnaz from Bandung, Indonesia. Dr. Andrade Montes de Oca from Guayaquil, Ecuador. Dr. Aninda from Bandung, Indonesia. Dr. Anita from Bandung, Indonesia. Dr. Arsi from Bandung, Indonesia. Dr. Berg from Sacramento, USA. Dr. Camacho from Almagro in Argentina. Dr. Effendi from Bandung, Indonesia. Dr. Avila from Bandung, Indonesia. Dr. Frega from Bandung, Indonesia. Dr. Fatima from Bandung, Indonesia. Dr. Habib from Islamabad, Pakistan. Bandung, Indonesia. Dr. Kesek from Bandung, Indonesia. Dr. Kusuhairi from Bandung, Indonesia. Dr. Lin from Guayaquil, Ecuador. Dr. Nurdin Syed from Bandung, Indonesia. Dr. Pollock from Guayaquil, Ecuador. Dr. Sari from Bandung, Indonesia. Dr. Smith from New York, USA. Dr. Tanaya from Bandung, Indonesia. And so those are all our active members as well as our training members. But I'd also like to invite our two GAP fellows, Cinema and Victoria, because they're also new members as of now as well. So I'm not sure how this photo is going to be, but if you want people to get a little bit closer, we're on the stage or something.
Kevin. So please come find me if you saw somebody up here that did not pick up their certificate. Congratulations, everybody.
One, two. Okay.
Based with David Mahler, after this meeting to find out, what exactly the usage rate was from our Paps members, because they, in theory, should have access to that data to find out how many people actually used it. But I suspect that likely this contract is going to be renewed for 2024. We've also did some advertising through previous meeting attendees at probably the last 5 or 6 conferences to advertise for new members, as well as using the other pediatric surgery societies to send out these types of emails for us to their members to advertise. And so what we've also proposed kind of going forward, given that we have so many training members, I mean, my goal really is for trainees to have a free membership, to be honest. And so what we've decided is that if they are involved in committees and helping out with planning for certain things, that they will receive a free membership for the year. As well, there's going to be discounted registration fees for Paps meetings in the future. And still in progress is an interesting case forum that, if they're involved with, every time, they make a message or make a suggestion or an answer or something like that, that they kind of get in the draw for a free membership as well for the year. And so these are our current members of our committee now. I would like to make a shout out to more Asian members to join the membership committee, because there is surprisingly no Asian representation in that list. And so, in general, it's not a huge division, but it is good to be able to kind of reach out through all these different avenues, especially to our Asian colleagues. It's just for representation. If you have any questions, anytime. Thank you.
A few things. We mentioned bylaws. We have a few bylaws to kind of clean up over the years. So the first thing is just getting into the more modern age. So Section 5 of the bylaws talks about electing the president, and previously it had been ruling as a written ballot only. And so the chances of us accomplishing written ballot is very difficult these days. So the one motion is to change the bylaws to be written or electronic. Okay, I'll have everybody vote, and we'll vote for everything. So that's one. The other is adding a section. Last year, Sarah did a great job of really editing the membership section with all the new categories and the changes in the application process. We missed one little section, which was about the board approving the membership. So historically, the entire membership approved the membership, but last year we changed the bylaws so that the board would approve the memberships after the membership committee vetted the applicants. So we need just one section here that says that the board is the one that approves it. That's number 2. Number 3, which is a little bit different as well, the certificates that you saw, I don't know if anybody has their certificates still, their Paps certificates. Do you still have yours? Kevin Pringle, do you still have yours? Certificate number 2? Do you have yours, Rob? So the old, and I looked at mine actually, the old certificate had all the board members, had the 4 officers, president, secretary, treasurer, and the president-elect signed, and it had all the board members. And so the chances of us getting all the board members to sign the forms is, again, very difficult. So the proposal is to change it to just the 4 officers, the 3 officers, the president, the secretary, treasurer, and then the chair of the nominating committee, since that person puts the most work in and does the approval. So that's number 3.
Why do you need the treasurer and the chair? I mean, all the certificates are just president and secretary.
We didn't want to change historic precedence too much. It went from, 20 names to, and then 2 names. If you go too much, you can't do that. But it was a good question. So we can make that by law change in 10 years from now. All right? So the president, secretary, treasurer, and the chair of the nominating committee. That's the criteria. This is another one, Section 19 amendment. This is about amending the bylaws. If we did it, it would be written and electronic as well, not just written. So that was just wording. And then this is an informational only. So the gap that Sharif mentioned, the gap committee, the language of the gap committee is in the rules and regulation. That does not need a membership vote for the bylaws. And so what he had proposed was that previous language was that the gap committee had to be approved by the board. And that's not what any other committees do. So the chair of the gap committee should be able to appoint the rest of the committee. It's basically what that language says, the chair and the vice chair. So we're going to make that change in the rules and regulations, which was already approved by the board at the board. So, anybody have any questions or comments? Okay, so we have the 3 bylaw changes. That's it. Okay, so the 4 bylaw changes, the written electronic for 5, and then 19, and then the membership approved by the board at number 10, and then the certificate changes. So those are the proposals to be changed in the bylaws, and that is membership. So I need a motion.
I'll move.
Okay, second? Okay, so we're just gonna have a raise of hands. All those approve of all 4, please raise your hand. Oh, beautiful. Okay, anybody opposed? Great, thank you very much. Business. Okay, we do have some new board members that last year and this year. Dr. Ono from Japan and Dr. Chen from Taiwan. And then with every year we have some board changes because we always have a new president for next year and then a new president-elect. So this is the new board coming up for 2024. So, sir. Okay, more business. So then every year at this time, we also will need to elect a new president-elect, and that'll be for 2025, which will be the meeting in Melbourne. Folks to be on the nominating committee. And as the nominating committee then will direct who, they'll do the vetting for the president-elect. So we need nominations for 2 people. So.
They cannot be board members, but they have to be present.
Yeah, must be in the room, cannot be board members. You don't want to be on the nominating committee? Claudia? Romeo? Romeo Ignacio's been nominated. Do we have any more nominations? Hold on. Paul Tam. Dr. Kim, you've been nominated. Do you accept your nomination? Okay, then we'll have to vote. Any other nominations? Carlo, would you like to be on the nominating committee? Did I nominate you? Nominate Kevin?
Thank you very much for, I appreciate the recommendation letter from them. I think busy for the nomination for, I will keep my talk for the next year. So please buy the round trip ticket to Hong Kong or one-way trip to Hong Kong to stay or later. But I will see the Congo next year. Thank you very much, Coach.
Dr. Obiyama, Dr. Robin.
Tadi presentasi Bapak ini ada?
Ada semua.
From a business standpoint, as Sarah mentioned, please update your membership and pay your dues, or Kevin Pringle will come to your house to get that money from him. We are now open for proposals for 2028. I'll announce to you the 2027 in a little bit, the 2028. And I already have one email already for one country that wants to be nominated for 2028. So, and this will be a quick turnaround because we're going to go to the spring in Hong Kong, so it'll be quick. And we are always open for other co-medal nominations. It does not have to be a yearly event, but if you feel someone is deserving, we can certainly move on to another co-medal each year. So. Sebastian.
Can I say something?
Yes, Raj.
We rejected yet.
Historically, the two non-winners may have stronger consideration in the future, but I think we talked about as a board, it's hard to keep that memory and keep that understanding, and so if you don't make it, we encourage you to apply again, but you have to apply again. You're not going to get credit, so maybe you have to come back several years in a row, maybe. I don't know.
Yeah, just to make a comment on that, I agree with what Coach had said. For all the countries that want to apply, we're going to, I talked to Sarah, we're going to put up something on the website. So hotels, you don't have to pick the hotel yet, but at least show the finances of how the meeting is going to run so that the board has a good informed decision. That's the way you're going to be able to win over the board and maybe be able to host the site. So we're looking at it to hopefully be helpful to you.
For those who don't know, Ahmed Nasser, who is the chief at CHIO, Children's Hospital East Ontario, trained in Toronto, and has done a huge amount of work with the CAPS group, particularly focusing on systematic reviews and looking at questions that the CAPS membership want answered, posing those questions and then bringing that back to the membership. So they've reached out about a particular or a potential affiliation with Paps. I actually happened to be in Ottawa last year, so I caught up with him towards the end of last year. We had a good chat about it, and he's very happy to support us and collaborate with us on that. So I think that'd be a good thing for Paps to be able to be involved with, to learn from the last 5-10 years that CAPS has been doing this. And I think that, as I said, I've already chatted to David, and he's very happy to support this, and that we can co-badge between CAPS and PAPS, which is a great thing. I also think that we need a couple of extra people to sort of put themselves forward to be involved in this, so it's not just Ahmed and myself, representative of PAPS and CAPS. So if you want to be involved, I've got one, I think that Sarah Chillian, a great person, loves systematic reviews and lots of work in that space. But if other people want to come up and have word and show some interest in that, that would be great, and then we'll be able to come back in 6-7 months until we're in Hong Kong, we can give you some more information about that. Any questions?
Karena nggak ingin makan di bawah itu aja tujuannya. Pengen makan di atas.
Thank you so much. And Mary Brendel, who has been the chair of the publication committee, is taking her spot in the, as the Canadian representation. So thanks for reminding me on that. Yeah. Okay, now for the fun stuff. Fun stuff? Not this. This is fun. No, not fun. Not the funnest. We're going to have a very quick turnaround for the spring meeting. This is the first time we're going to transition back to the spring. And so Ken in Hong Kong has the noble task of trying to get the meeting together quickly, and then the scientific committee and program committee putting together quickly. So I have some slides where you want to mention all the great stuff in Hong Kong.
Well, all of you in this room expect me to be there next year in Hong Kong, especially those new members. So the date is fixed, 28th April, 2nd of May. What is slightly different this time round is that we'll be hosting this in conjunction with the Asian Society meeting as well, although it's a separate event held in the same venue in America, Hong Kong. So will be lots of people to be in Hong Kong as well. So this is the brief rundown of the usual Paps sort of timetable. So the AAPS will only be together with Paps on Monday and a tour on Tuesday as well. Hong Kong needs to sort of sell itself is so famous for the sites, the location, the ease of transport, and the food especially. Easy place to get to anywhere in the world, America, Europe, anywhere in the world to get to Hong Kong within 12 hours. The hotel itself is almost brand new, opened 3 years ago, before COVID. The room rate went down to between $680 per night, which is very cheap, including breakfast. Also, it's a fantastic resort. It's next to a theme park, Ocean Park, with lots of roller coasters and water world next to the hotel. And what is good about the hotel is a resort on the south coast of Hong Kong Island, and it's one subway stop to the center of Hong Kong. So just 5 minutes get on the train to the center of Hong Kong. So the shopping, spend money in Hong Kong as well. The Congress tour will be going towards the New Territories and Cyclone region. We'll take a boat to look at all these amazing formations, and then after the boat trip, we will go to Cyclone Sea Village to have a seafood dinner, included in the restricted fee as well. Possibility of pre or post-Congress tour to Macau. Let's just call it the mini Las Vegas, with starch bigger than Las Vegas, so take a seriously. So we look forward to seeing you, all of you, in Hong Kong next year.
Any questions or comments? Okay, so as a reminder, the year after Hong Kong.
So it'll be 55 years since Melbourne hosted Paps. It was 1977, it was down the road, down Great Ocean Road, I think. So yeah, it'd be great to have Paps back in Melbourne in 2025. We're also going to be co-badging with ANZAPs, like the Christchurch meeting, like the Hunter Valley meeting, like the Queenstown meeting, the Sydney meeting. So yeah, so hopefully be able to bolster a bit like with our large Indonesian contingent this time, be able to bolster the numbers of the Australian and New Zealand surgeons as well. We've got a whole bunch of fun stuff planned, including potentially trips to the football, maybe on Saturday night before the conference starts on the Sunday, and some winery tours, and of course, based on the people that are going to come in, we'll probably go and look at some Australian flora and fauna as well. So I'm looking forward to doing that. It's only 18 months away now. So we'll obviously get Ken's extravaganza out of the way first, and I'll have some more information when we meet up again in April next year.
Okay. The year after Melbourne will be in Houston, and if you don't have a flight, we're going to give you one of these to fly to Houston. We'll come pick you up, bring you to Houston, okay? And it'll be probably March, April will be the time. We don't have the specific times yet, but we're going to get there. Okay, so the board voted for 2027, a tremendous presentation by the Japanese Paps group for Okinawa in 2027. And so, how many years has it been since we've been back to Japan? Since support? 2018? 2018? 2018, okay. Very excited to go back. Does anyone want to make a comment? Okinawa?
In Japan, the 2027 Okinawa. The last part meeting in Japan is 2018 in Sapporo. Professor Kuroda has a successful meeting. Attended over 400 members joined that meeting. So we plan just now, from now we plan the tremendous attractive meeting in Okinawa 2027. Maybe from Hong Kong, 300 attendees coming to the Okinawa. Thank you so much.
For just a few minutes, we usually have an exit, quick exit meeting for the board. But then